We're probably at 10 o'clock now, so I'd like to start the meeting. My name is Jill Taylor. I'm the chair of the People and Health Scrutiny Committee. Welcome everybody in person. This is our first face-to-face meeting, and it always comes as a bit of a shock, I think, when you meet people that you've worked with online for the last 2 years, and suddenly they're real people, and you find out they're taller, or they're shorter, or they look totally different when you actually meet them. And it's wonderful to see people face to face, because I think the one thing that we have missed is the human side of meetings and being able to interact with each other and talk to each other. Now, as you're obviously aware, we're in the committee chamber at the moment. I would like some feedback from anybody as to what works, what doesn't work. I've set the chamber out as I think might work, but obviously until you actually try it, we don't know. So welcome everybody today. If I can start, just a point. One thing that we have noticed with people online coming back face to face is about the use of microphones. While we're using microphones, it goes out on YouTube and works really well. What doesn't work really well is when we interact with each other. So when we start talking to each other and then you turn around to talk to somebody else, you don't get the microphones, you don't get it onto YouTube, and any members of the public watching out there are going to miss quite large chunks. So just bear it in mind that when you're talking, just stay fairly close to your microphones. Thank you. Could I have apologies, please? Sorry. I've got apologies from Molly Rennie and no other apologies at the moment. Okay, so we've got 1 or 2 absents. Because we haven't got Molly vice chairs for me, I'm just wondering if I could have another vice chair. And I think from the chair, could I nominate Councillor Ireland, please, if there's a seconder? Yeah, I've got a couple of seconders. Okay. Councillor Ireland, would you like to come and join me at the front and just give me a hand, please? Thank you. Right. If we can now move on to declarations of interest. Has any member got any declarations of interest they'd like to mention at this stage? Otherwise, sorry, Councillor Ireland.
Yeah, just my usual ones. My wife's a matron at Yeovil District Hospital. My daughter is currently working as a locum in Dorset and as a doctor, and I'm also a governor of Dorset Healthcare appointed by this council. So.
Thank you. If anybody else has any declarations that they can think of during the meeting, please let it be known. Item 3, minutes of the last meetings. Now, we've got several of those, I think. Because we're on to a face-to-face meeting, we've got to approve all the minutes of previous meetings, I believe. Is that right, George? Yeah, it is. Okay. Can I have a proposer for the minutes of the previous meetings, please? Thank you. Could I have a seconder, please? And could I just vote through all of the minutes en bloc? Thank you very much. I've got a couple of minute updates that I'd like to draw to your attention. The first one, at our last agenda meeting, we asked for a paper to be circulated on how councillors can help with the care sufficiency. So I have put that out. Feedback on that would be really, really useful. And looking at how we can, as members, can support our communities at the time that care sufficiency or almost insufficiency is actually quite dire in Dorset. So we are looking for volunteers for help, whatever we can do. So feedback on that document, feedback on how the communities are using it would be really, really useful. I've got a second update that I'd like to put into the minutes as well, which is around the Swanage car service, which is an issue that has been around for, must be about 2 or 3 years at least. What I'd like to do is to pass over to Sue Sutton to give us an update on that. This is very much a CCG ambulance trust issue. This is not a council issue, and I'd like Sue to give us an update, please.
Thank you. So the CCG and SWAST issued a joint letter to residents last week to say that the listening process, the listening exercise that we've been undertaking, it has closed. I'd like to take the opportunity to thank all of the people that took the time to share their views with us, which was very much appreciated. Next steps will be to ensure that the car is, the shifts are filled. Obviously, we've heard concerns, and it has been a subject of discussion between ourselves and the Ambulance Trust as well. Obviously, the issue of COVID and the impact on workforce has impacted the car in the same way it has all other health and social care services. So that'll be our next step to work with SWAST on that. Thank you.
Very much for that. Can I move on to the next agenda item 4, public participation? Do we have any members of the public wishing to speak or of putting questions, please?
There's no public participation.
Thank you. And now we move on to questions from members. Are there any questions from members? Can you put your microphone on, please?
Right, sorry, thank you. Sorry, Chairman, thank you. I'm not sure whether I need to declare this at every meeting, but I do have a disabled son who doesn't live at home. Thank you. Yeah.
Thank you. Okay. So I take it there are no questions from councillors? Okay, thank you. Can we move on to item 6, integrated care system update through winter? And I think we have an update on prevention from Becky Whale and Kate Culvert, I believe. Okay, from Becky. Sorry, Jenny Crawshaw. Okay, can I pass over to Jenny Crawshaw for an update on this, please? Thank you.
Chair, is this okay if I start? It's Sue Sutton for the ICS paper, and then I'll hand over to colleagues Kate and Jenny for the Home First prevention update.
Absolutely, please do.
Thank you. Okay, so members have the paper in your pack. The appendix that's referred to is the Home First update that colleagues received at the last meeting. And as the Chair says, we've got Kate and Jenny here, who I'll pass on over to when I've just run through some headlines in the paper. I don't intend to talk about the information that's in the paper. What I will do is just talk to you very briefly around the kind of situation over the last kind of few weeks. The paper does refer to the fact that the Dorset system, so the integrated care system as a whole, has been in the highest level of escalation. So that's OPEL 4. Since the 8th of February, which is referenced in the paper, and that situation has continued, so we're still at that highest point of escalation. What that means for our services is that along the urgent and emergency care pathway, and when I say that, what I mean is if you phone 111, if you are then spoken, if a clinician within the 111 and integrated urgent care service talks to you over the phone, if you have an appointment at an urgent treatment centre or an MIU, if you arrive at the emergency department or in an ambulance and need to be handed over, if you are admitted to hospital and then required to be discharged, all points along that pathway are under pressure, and every service is experiencing pressure. There are a number of reasons. The paper references workforce, which is a significant factor. Obviously, the impact of COVID and services now needing to catch up from the impact of the pandemic over the last 2 years. What we are doing across the system as a whole, across services as a whole, are carrying out a range of actions and interventions at short, medium and long term. So the shorter term are the ones you would be expecting us to take in terms of what are the things that we can do to get out of the initial pressure that we're under. So when you see ambulances queuing outside our hospitals, for example, and then more medium and longer term actions. So things like if you phone 111 and you're waiting for the call to be answered, it's because the pressure, how can we get more call handlers? And if you do speak to someone in 111 and then you require to see your GP practice, for example, which is sometimes an outcome of that call, that then you could be direct into your GP practice surgery as opposed to then calling them back. So things like this that are kind of actions that sit along all points in services that then allow the flow through that pathway that I referred to become more seamless. So the cumulative effect of a range of actions having an overall positive impact on the pressure on the system. There's quite a lot of information in the paper. I'll just pause there, Chair, and happy to take questions, of course.
Questions? Okay. Councillor Legg.
Oh, that one. Okay, right. Good morning, everybody. I'm not entirely certain how far and to what degree of detail you want me to go in to raising questions on this paper at the moment. I know Nick has got a number of questions. I've got about 2 pages of questions, which is, I think, probably rather too many, but there aren't very many members of the committee here this morning, so perhaps I could make up for those people who aren't here. My overall impression on this paper when I read it was that I was shocked. I mean, it paints a very alarming picture of what's happening in the county and gives an impression on a service which is at the point of collapse. Do you think that's an unfair comment? Oh, yes.
So I think it's fair. Observation. The fact that we are in our highest level of escalation does say that all systems are under pressure. So yes, it is an extreme time, certainly, and the most extreme that I've seen in my 6 years working in the Dorset system.
Can I say, Chairman, I think one of the things which I felt was missing from the report was that there were hints of, well, heavy hints of where there were issues and difficulties and problems. But I would have liked to have seen, without trying to make the report even longer than it is, some actual specific details. For example, you talk about a care hotel with 16 beds. I don't know whether that's a lot or not very many. I'm not certain about how many people are currently sitting, or lying rather, in hospital beds, who really ought not to be there at all and ought to be somewhere else. And therefore, is 16 beds in a care hotel an appropriate number? Do we need 10 times as many beds in a care hotel? The performance on 111, for example, is given in December at 43.2%, where the national target is 95%. And there's a kind of hint that the reason for that is that there is a kind of cascade of dealing with 111 calls where we can be put under pressure because other neighbouring call centres are not able to handle their call volume, and so we're getting some of theirs as well. But there's no kind of idea of what, you know, if we were isolated, if it was just Dorset and Dorset's call centre handling the calls, could we cope? Or are we under pressure just within our own patch? And if I can return briefly just to one hobby horse, and that's the closure of the minor injuries unit in Sherborne. You've closed temporarily the Portland, Sherborne and Blandford Forum centres. Why did you choose those in particular? For example, Sherborne is quite close to the District General Hospital in Yeovil. Is that a reason for shutting Sherborne because it's considered to be close enough to Yeovil that people can go over to the A&E in Yeovil and be dealt with there rather than travel somewhere else? And it also refers to a review being conducted by the end of March. I mean, it might be that you've already, since we're a good way into March now, you might already have made the review and made a decision. So there's lots of sort of unanswered questions, and I'm going to leave a few more for my colleague Nick to return to, because I dare say he's got quite a few as well.
Thank you. Would you like to comment?
Thank you. So I'll take 111 MIUs and then finally I'll do a double act with Becky if that's okay. So in terms of the 111 performance, actually the Dorset system performs quite well compared to others across the country. So I think we're tracking at about 10th in the country at the moment. So the 45%, obviously that's a December figure against 95%. About a year or so ago, that target was being met. There are a number of factors. Workforce for the call handlers. Dorset Healthcare as lead provider for the Integrated Urgent Care Service are actively recruiting more call handlers, but workforce is a factor. We are a high provider of support to other areas and a low user of the National Contingency Arrangement. That is changing. There is a national project underway, and we're working with colleagues across the Southwest to see how the Southwest could support each other first before we went more broadly across the country. So that's a kind of medium to longer term piece of, well, medium term it is due to start in the next financial year. But no, if it was just the Dorset service, it wouldn't be performing right now consistently, but there are very robust plans in place to improve that trajectory so that a service will be performing again. In terms of the minor injury units, I haven't got the exact criteria to hand with me here. Dorset Health, that was a short-term action that was taken again due to staffing, and so that the remainder MIUs could be staffed, and there were additional hours put in at Wimborne, for example. But I can get an update. I did try and get an update actually on the MIU issue before today, but wasn't able to. But we can provide that after the meeting. And absolutely, the Urgent and Emergency Care Board is actively looking at this issue, and that's going back to the next meeting in May. But we'll provide that update for you. Absolutely, we have many people in hospital at the moment that's not necessarily now the right place for them. And they're ready to move on. The 16 beds we've not put a care hotel in place before. We've taken some learning from other areas, but compared to our hospital bed numbers, it is quite a low number. But I don't know, Becky, if you wanted to come in on that.
Yeah, the care hotel was set up at pace immediately in the post-Christmas period, recognising that we had a lot of ongoing shortages in being able to move people out of hospital to find a suitable space for them. The 16 beds was trialled, I guess, as a proof of concept. It's for low-level needs, so you can't take high levels of patients that have any degree of complexity into that space, but it is a suitable kind of, I guess, bridging space for people where they can be supported with the right care whilst they are waiting to go home. So we opened that in January. And that has been running well since. We do have, across our 3 acute hospital sites, we have about 300 people currently that are waiting to leave the hospital. That number has been fairly static for the last few months. We are obviously endeavouring to bring that down as quickly as possible, but it's really about finding the right places for people to go.
Thank you. Can I come in on the care hotel? Thought has just occurred to me that setting up this sort of thing costs quite a lot of money. And where I'm sitting at the moment, I'm thinking that DC's social services, who would normally support those people, could well use that money better and support more than 16 people with the money from that. And I know there's a problem with sufficiency of carers, but I'm just wondering whether there was a conversation between health and DC about how best to use that money. I appreciate that the care hotel, I believe, is staffed from non-UK residents. But, you know, it's just the question, could we better support people by not having that? Thank you.
Yeah, I'll respond on that. So I think, it's worth saying that the care hotel was stood up as part of our surge capacity. So it was action that we took in extraordinary circumstances, recognising that all of the options that you've just described in terms of where we could invest in additional home or bedded care within our current facilities, we had pretty much exhausted at that point in our ability to stand it up very quickly. It was a model that we are encouraged to pursue nationally, so it's a national, the care hotel model is one that is nationally kind of been recognised as our ability to help in surge. It is a short-term measure. I don't know that we are necessarily at this stage thinking of it as a long-term commitment. This particular site was adjacent to Bournemouth Hospital, so it supported mainly clients that live in the BCP area and was supported obviously by the BCP social work teams as well as the health teams that sit on and around, in and around Bournemouth Hospital.
Thank you, but just coming back to the original question, were there discussions with DC as to the best way of actually doing this, whether a care hotel was the best way, or whether DC could provide more for less? I think I've got an answer over on my...
Thank you. I'll answer on our behalf. So thank you. I'm Leslie Hutchinson from Dorset Council. To agree with what Becky's just provided, it was a close discussion. We had a lot of scrutiny, didn't we, together about what was the best way to spend the money given the resources that's available. But it was a system discussion that took place, and there was a fair amount of challenge that we all gave to each other about, because it is significant funding that's going in. It's coming from the government pot of money that's come down to help support hospital discharge. So it's a ring-fence pot of money, if you like, that goes into providing those services. We looked at a variety of options, not least with the incumbent provider of that care hotel, to say, actually, because one of my challenges was, could those staff work within the community rather than working in a hotel environment and have a greater spread? But it was really clear following discussions with the provider that just wasn't going to be a possibility. So what it enabled was a number of people to be supported in one place. We looked at every option, to be perfectly honest, but there was a lot of pressure nationally, as you've said, wasn't there, to have this on board. And it was certainly one of the questions that NHS England and NHSI asked when they came to see us. And it was certainly one of the questions that Department for Health and Social Care were asking was, how quickly are you going to stand this up? But we did look to check whether that was the best use of the funding at the time.
Okay, could I just ask, just coming back on what you said, that they couldn't work, why couldn't people work in the community, but they could work in a hotel?
So the company that we use, they specialise in the provision of support for care hotels. So it's often about the accommodation as well as the delivery. So what they were setting up, how they've deployed their resource, not only in our care hotel but in others, is that you provide them with the accommodation in the hotel as well as the care support. So the model that they provide is they keep them as one team rather than disperse them around the county. It's their model of care. They don't currently do a dispersed model because they bring people over at pace. I think we brought them over within a matter of weeks, set them up in the care hotel and mobilised within a few days of that. So it's their model, it's the way that they work. We did explore that. We did ask the question about whether we could use them in some sort of roaming capacity, but it wasn't an option. They weren't able to do that for us.
Thank you, Chairman. When these discussions are going on between the health authority, if I use the old-fashioned phrase, and the Dorset Council, to what extent, if at all, do elected members get involved in that discussion? Because it just strikes me for a moment that elected members don't have any input into this whatsoever. Sorry to be critical, but there we go.
So I think there are mixed points in time about where that conversation takes place. Certainly we've been being very open and transparent at the November Scrutiny Committee and then again in the January Scrutiny Committee where, as Dorset Council, we've brought routine papers on market sufficiency and we've been very open and transparent about the situation and referenced the care hotel actually within that paper. I think in terms of the build-up towards making the decisions around what's the best use of funding, that happens across system partners. Our portfolio holder will have conversations with routinely, as you'll be aware, but in terms of that direct decision making around where that funding is spent at that moment in time, that's led between the organisations rather than at member level. This is the place, I think, in terms of having that scrutiny of that conversation. I do wonder, actually, whether there's a place in overview, whether some of that decision-making can take place. But the pace at which some of this is happening, it's within weeks, isn't it, around having to mobilise and set some things up. So we probably need to give a bit of thought to that, unless you want to add something in, Vivian.
And I also think it's important that this is a system conversation. So this is an across the two councils discussion that was happening and making sure we got the right support and facilities in place. So a lot of that discussion is had with our health partners, and also we are keeping our portfolio holder very well briefed on this and the wider cabinet. So yes, there's always, in terms of hindsight, very helpful to look back on what's the learning, and we're doing that on a weekly basis, looking across with our system colleagues and with our portfolio holder about what else can we now learn from this, what can we do differently, when we're also looking across other systems, because we are not the only one in Dorset who are having to work at pace, but also with the amount of people no longer having a right to reside in hospitals. So it's a sort of very joined up conversation, and it's a fast moving conversation. But I think nationally, there isn't an easy answer to this. It's been well thought out. We've had many conversations with across the South West and across national conversations about what's best practice. And we are sharing that on a very regular basis with our portfolio holder to make sure that he is fully briefed and understands the options that we do have available to us.
Thank you. Can I go to Councillor Ireland now for questions?
Yeah, thank you. I had a load, but I think quite a lot of them have been answered by you in response to Councillor Legg, so I'll skip those. I think the first one is there's a quick question on the MIUs. So I appreciate Dorset Healthcare isn't present, but is the CCG involved in the review that's going to happen at the end of the month? And if you are, do you have an expected outcome, or what would you like to be the outcome? And I'm assuming if the outcome is reopening, how long is that likely to take? So that's the first question. I'll give you some others, then you can save time. The breaches, the 12-hour decision to admit in UHD Poole, it said specifically, why Poole? Why not Bournemouth? Why not Dorset Hospital? And I think it's already been answered, we're not planning to open any other care hotels, I think. Okay. Moving on to, I need a bit more information on future developments. So you're looking, you've got funding for 2 years, non-recurrently, so I think 2 years, then it stops, about right-sizing the clinical workforce in the clinical assessment service. So it's 15 WTE, so 15 people, or 25 or 30 part-time, I guess. So what happens after the 2 years? Does that mean they disappear and then you won't be right-sized anymore? And the final one is the tactical opportunities. The table at the end has got some timescales in, so it implies it's already started. It's starting Q1 24, Q4 21, 22. So the one big question is, who's leading on this? Is it the CCG, and does it include all the trusts in Dorset? And the first timescale, which presumably has started, it says target interventions to test, which sort of implies it's unclear which of the big list will work and what benefit they'll bring. So I guess, how's it going? Which are working well, which aren't? Do the savings, 6 million to 12 million, basically? Do you think they're realistic? What do you think is likely to be achieved? Sorry, it's quite a few questions, but less than I had.
Thank you. I'll respond in the order that you asked them. So for the MIUs, yes, CCG is involved. We have a system board, so urgent and emergency care board, that includes partners from all organisations, including Dorset Healthcare. So as I referred to earlier, the decisions around the temporary closures were short-term decisions because of the impact of reduced workforce. And the UEC board will oversee any decisions. So no permanent decision will be taken about reducing staffing or closing an urgent treatment centre. There would be a process around that, but it is that board that oversees that, and they'll be expecting an update back at their next meeting. It does form part of a wider piece of work that the UEC board's overseeing as well. So that pathway that I talked about earlier, the bit that's outside of hospital, how can we make sure that patients have the kind of optimum number of touch points? So at the moment we've heard largely anecdotally, but quite a lot of anecdote around patients having more touch points than are required, so accessing services in more places at more times than is actually required to meet their need. So that's not good for patients. It's not good for people, for our families, all of the residents of Dorset. So we know we can do that better, and the urgent treatment centres is part of that piece of work. Sorry, your second point. Could you just point me in the paper to what that relates to? I didn't quite catch what that was. Sorry, your second point.
So this is about.
You just. Sorry.
It was 14.2, so there was multiple breaches and 12-hour decision to admit in pool. And it just says, it said particularly University Hospitals, Dorset Pool. So I just wonder what's special about Pool. Why not Bournemouth? Why not, DCH?
Thank you. So bed occupancy has been consistently high over winter at all three hospitals in Dorset, and waiting times. So it does specifically talk about UHD, but the pressure is consistent across the three trusts. Sorry, the two trusts and the three sites. The care hotel question. Sorry.
Yeah, we have no plans to extend the care hotel model beyond the current period.
Thank you. The right sizing of the clinical assessment service. So what that's referring to, I referred earlier around carrying out recruitment in order to increase the call handlers for 111, so those that are answering the call. The system that the 111 uses, there's kind of an algorithm, then produces a disposition, so it gives an indication of what the system thinks could happen next for that patient. What we know from evidence from other areas is that if a clinician revalidates that decision, so revisits that decision that the algorithm has made, that in a very high proportion of cases, often that can be downgraded. So if the system's saying you need an ambulance or you need to go to hospital, actually if you speak to a clinician, quite often that would not be the case. It might be something else that you require, either pharmacy or a GP appointment. So it's really important that we can maximise the number of clinicians that are in that service. It's called the Clinical Assessment Service. It's part of the overall 111. So that's what that's referring to. Your question around the funding. So finance is obviously pressured at the moment. The 2 years non-recurrent. We know that that needs to be funded recurrently. There just wasn't the recurrent funding to be able to identify to that service, but we do know that that is something that we need to do after the 2 years ends. Sorry, there was a final point about the appendix, I think, Becky, if you could take that, please.
Of course. So your question related to the tactical opportunities that have been identified as part of the next phase of the Home First programme, which, as you'll recall from the paper, is about the long-term development of our intermediate care model. So the tactical opportunities have been identified as part of the work that we've been doing with our strategic partner, Empower, over the last 6 months, which is really looking at our current model and identifying where there is scope, I guess, to make it work more effectively, to get more outcome from it, to take the learning from best practice around the country and really kind of, I guess, stabilise the platform on which we want to build our future model. A lot of that work is already happening. So Kate and Jenny are here to talk particularly about the emission avoidance piece, which is part of that. We are working across all 10 of those opportunities. There are elements of work already happening. What we're really looking to do now is to scale up the pace of those over the next year as we move out of our kind of incident response phase and into our long-term model phase. For that reason, I don't think the benefits are yet visible in the way that they're described in the paper. We would expect those to be delivered over the course of the year, and we've got kind of quarterly gateways in to check that we're on track to do that.
Just to come back to the clinical assessment unit, I didn't realise there was an algorithm. So you just implied that the algorithm you've got, basically you said it doesn't work very well, and so you need all these people to... So the officer's question is there any work stream going ahead to identify the deficiencies in the algorithm? And yeah.
So the 111 service, the title of the service is Integrated Urgent Care Service. It comprises a few things. So there's the 111 as you understand it in terms of making that telephone call. What sits behind it is that clinical assessment service. The system's called Pathways that the non-clinical call handlers use. It is the service is nationally mandated, so it's not something that we have chosen to commission in Dorset. It is a national requirement. There is a national group that looks at how Pathways works, but it's a non-clinical call handler using that algorithm. A clinician talking to a patient will make in some circumstances a different decision.
Thank you. I've got a couple of questions. One of the questions is around section 21, which is on your workforce. You talk about sickness absence and staff vacancies, but you're not giving us any figures on that. And I'm just wondering what your sickness absence is like, because obviously staff are under an awful lot of stress at the moment. They're burned out after COVID, and I'm just wondering what I'm really looking at long term, not the odd day off, what your absence record is like, and how many vacancies are you carrying at the moment?
Thank you. So we did just have a look at some data earlier. In February, 36% of workforce absences were due to COVID. In terms of vacancies, I don't have that to hand, but that's certainly something we can feed back to the committee after the meeting.
Okay, and this actually relates to my main question. With regards to, you're obviously on Opal 4 still at the moment, and I note that the ambulance service are on REAP Black, and they have been on that since last June. I'm just wondering, when does it get to the point that this is normal and you have to reset? Because that will obviously take quite a lot of resourcing, a lot of planning. And when do we actually start looking at this in a sensible way? And that is also for social services as well. When do we actually start saying this is normal and start from scratch again, basically?
It's a very good point and question, thank you. And something, in fact, that our executive group, which is again is our highest level of escalation, have been talking about only last week. And in fact, what we don't want to do is normalise this. We want to be able to make sure that we've got robust actions on those short, medium and long term, or in particular the short and medium term, so that we can de-escalate from that position. So we don't want to normalise it. We want to make sure that we've got robust plans, and that the things that we are doing, the actions that we're taking, are having the impact that we think that they will and should have. And if not, we change. We do something different.
That actually quite concerns me when we've got the ambulance trusts that are on REIT black for 8 months. That is normal. That is not something that's going to change overnight. And year on year, we seem to hear about winter pressures carrying on through the summer. And this is normal. This is post-COVID, but this is normal as far as what I'm seeing. And the same with social services. It's becoming normal. And I know it will always be an issue of how we fund it and how we split the funding between health and social services. But at some time, I think we're going to have quite an adult conversation around all of this and re-normalise things. It's just my opinion. Can I come to... are there any more questions at the moment? Councillor Penfold.
Thank you, Chairman. Could, with 11.1 on primary care, with the 3.4 million which we've been awarded, could we be sure that this will be an improvement, and would we be able to have a feedback on this?
Hi. Yes, we're happy to feedback. We've got robust plans in place in terms of that investment for general practice. Some of it is about addressing the backlog that practices have incurred, particularly around phlebotomy. So, but yeah, we're really happy to bring a more detailed paper back.
Thank you. Any more questions? Okay. If I can go to the second part of the presentation, which is about PREVENT, which is what we asked for from the last committee meeting. Thank you.
Hi, I'm Jenny Crawshaw and I work in the primary and community care team at Dorset CCG, and part of the work that I do is on the Ageing Well agenda. This sits under the Home First Board, which I'm sure you're all aware has a greater focus on discharge to assess, getting people out of hospital. The work that we predominantly do is actually at the other end and preventing people from going into hospital in the first place. Okay, next slide, please. So here is just a quick diagram really to show you the work streams that we're currently working on. Ageing Well has main 3 areas, which is enhanced health in care homes, anticipatory care and urgent community response. However, sitting under that umbrella of Ageing Well, we have some work around end-of-life care, virtual wards, which is something we're focusing on at the moment, and falls as well. Next slide, please. So within the enhanced health in care homes work, we've made quite a lot of progress over the last few years. Each care home has an assigned clinical lead attached to a PCN, which is a primary care network, and are delivering against a contract that came into place since, I think it was October 2020. Last year we did a piece of work actually to identify conveyances from care homes and the reason for that, and that work showed us that actually 71% of those conveyances were appropriate, 25 conveyances were inappropriate, and there were 4 that were undecided. That was due to a lack of information once we carried out this audit. One of the biggest issues that we found was for the ambulance service on site was the lack of care plans available to view at the time that would have stated the patient's wishes and also given an understanding of a state of normal health for that resident. Had we avoided those inappropriate conveyances, we would have saved 116 bed days. Next slide, please. So what we did with the findings is we presented this to various groups across Dorset, and SWAST has since introduced a training module for all new paramedics and as part of their annual training, which shows paramedics what a care plan is, what it means, also what their authority is in acting on that care plan as well, because sometimes I think when you're on scene and you've got patient's family, the patients themselves inputting into what they'd like to happen and a robust care plan, you're probably more swayed to acting on the information that's right in front of you rather than a document that you're not sure when it was last updated. So there's been quite a lot of training with our paramedics around their responsibility and their authority to act in connection with that. Primary care as well has recognised that since the pandemic that they probably need to, or they do need to revisit these care plans that they have in place for residents and ensure that they're up to date and hold the most relevant information. There's also, as a side to that, another piece of work that we're doing to ensure that care homes and GP practices can communicate electronically a lot better than they do now, and that care homes can have access to the most recent and most up-to-date care plans. Currently, a care home will print off a care plan and hold it in a residence folder, which may not be the most up-to-date, hence the issue I referred to earlier with paramedics being able to trust that document on scene. And again, our care homes have access to MDTs generally weekly, almost certainly a monthly MDT, where residents are brought to an MDT for discussion and escalation to review the best course of treatment for that person to prevent an admission. Next slide, please. Okay, we've also just started another piece of work with a small pot of funding that's not recurrent around non-injury falls. So we have a high proportion of residents who are discharged on scene by the ambulance service for a fall without an injury. So that means they weren't taken to hospital, and that means that actually with a different approach, that resident could have avoided having a call out by a paramedic to help get them off the floor and check them over. So the piece of work we're looking at the moment is to support and enable care homes to safely lift the residents themselves with a piece of equipment, but also more importantly, to ensure that that equipment doesn't gather dust in a corner, is to have that clinical governance and support around for them. And that would be by way of a pathway for clinical triage, should they be concerned. There would be a process in place that would guide the care homes through lifting the patient. And if they're still concerned at the end of that, they would have the ability to have phone contact with a clinician to ensure that actually they're doing the right thing. If they're still concerned about the resident's health afterwards, then a visit could be arranged by the Urgent Community Response Service, which I'll come on to in a moment. So at the moment, we're at the phase of identifying care homes where we'd have the biggest impact in reduction of call-outs for emergency services. Next slide, please. As of the 31st of March this year, it is nationally mandated that an urgent community response service be in place that has full coverage of the county. The urgent community response is a 2-hour response team, and there is no wrong door in terms of referral source. So that referral can come in from GP practices, from emergency departments, community services, 999 111, social services, for instance, if there's a breakdown in care provision, and many others that I'm probably not mentioning at the moment. At the moment, we've started rolling this out as of July last year, and we have, by the end of March, we will have full county coverage. However, there is still some issue around recruitment into roles. So the roles are advanced nurse practitioners or paramedics with therapists in cars, and we've currently got 2 roles that we haven't fully recruited into at the moment. So whilst we will have full county coverage, the number of referrals we'll be able to accept into that service may not be as we would expect. So at the currently, the service has the ability to hold patients on a virtual ward once an intervention has been made, and the reason for this is that often you'll go out and treat the immediate emergency, but actually there's an underlying cause that's created that crisis, and rather than either pointing them back to their GP practice or not following up and risking that crisis flares up again, we'll be holding patients on a virtual ward for up to 72 hours, which will be managed by a nurse-led team. Also, as part of that service, once they've responded, if there is other needs identified, then that patient will be referred on to other services for ongoing care and assessment, and it could be either the frailty teams or the therapy teams to ensure that actually that crisis doesn't reoccur again, or that a care package or plan is put in place to support the patient. Okay. Also at the moment, we're using a third-party organisation for welfare checks for patients as well. So those who may not necessarily need to sit on a virtual ward, but it's a good idea to keep in touch with them for a couple of weeks just to make sure that they're doing okay. Next slide, please. So this is the proposed model at the moment and what we have been testing out. The Urgent Community Response Service sits under the IUC, the Integrated Urgent Care Team, and they're currently directly pulling cases from the 111 stacking list. So they're identifying patients that would be suitable for an urgent community response, and they're actually preventing that call being escalated into 999 in the first place. Also, we've been working with 999 to triage patients and refer them directly into the service as well. So that's underway at the moment. Needs some tweaks to how that works, but on the whole seems to be working quite well. Within SWAST, we have a dedicated clinician sitting within the hub who is triaging patients just for Dorset at the moment. And as you can see there's the whole pathway around how we escalate and what we do with that patient. If it's deemed that the best response isn't an emergency car for the patient, then we'll refer on to the locality teams under SPOA. So it could be that a therapy team are the most appropriate person to respond, or it could be that a district nurse could go out and also respond. Next slide, please. So the next steps for urgent community response is to introduce another element or dynamic, should I say, from primary care itself. So this is a system response. Primary care currently provide a response for their frail patients at the moment, and probably are already doing that within 2 hours. What this is going to be able to do is give the UCR service the ability to divert patients that are known to the PCN to their frailty teams for a response and follow-up, or for follow-up, should I say. So we're actually just working with our primary care networks at the moment around what that would look like and how the best way actually of being able to approach that. It's really about truly integrating the services across organisational boundaries. There's also the opportunity with linking the UCR to out-of-hours services and night service to be able to provide a 24-hour service. Whilst this isn't naturally mandated at the moment, it is an ambition of NHSE that this will become a 24-hour service. And there's another element to the UCR, which is a 2-day response, which is rehab and reablement. Whilst we are ticking some of that box at the moment, there is a need to really engage with our local authority partners to look at how we can support patients with ongoing care needs as well. Next slide, please. So I'm just going to briefly talk about anticipatory care because we're just starting on this at the moment. Although I say we're starting on this, I think actually in Dorset we're a bit further ahead than most counties, and we've had work around anticipatory care going on for many years now. And that's been in the form of our frailty teams and also the investment made into integrated primary and community care services a number of years ago. The focus nationally from NHS England is on the moderately and severely frail population. And I think in Dorset, this is where we're probably a bit further ahead of the curve because we have a couple of services in place focusing on those severely frail patients at the moment. Another area is health inequalities and also to focus on people who rely on unplanned care to manage their conditions. So last year, we had some funding come down from NHS England, and we really approached allocation of that funding in a very different way for Dorset, and I think probably nationally, actually, whereby we really looked at the data that we have around our population, and we used that to allocate funding based on need rather than the number of patients in any area. And for that, we looked at deprivation, rurality, and I'll explain in a minute why I think rurality is quite a key thing to consider. Frailty of all levels, mild, moderately, and severe. We risk stratified our population as well, so we looked at the risk of emergency admission within the next 12 months. And just for clarity, that's based on patients of the age of over 65 and over, and their risk of falls as well. So based by primary care network, we had a look at those risk factors and those areas and allocated funding based on that. The reason I think rurality is a key thing to look at is that actually when you're looking at providing services in the north of the county or over in the very west of the county, where patients are a lot further away from either GP practices or hospitals, and you're looking at taking services out into their home, we really need to consider the time to travel for staff to get there, and that actually you're likely to have fewer contacts in a time scale that you would have for a member of staff in a more rural area, more urban area. So it was really important to consider how we can provide the best service for those patients who are really quite rural. Next slide, please. So this is a diagram really that describes NHS's ambition around anticipatory care, and it's nothing for us that's very surprising, and again, something that we've been doing for some time now, which is identifying your patients, those who are frail and have a number of long-term conditions, having a plan in place to address those issues for them, and then also supporting and putting in implementing some support and review for those patients as well. I think it goes without saying that actually the pandemic has probably restricted how much we can do in this area, hence the key focus at the moment. Next slide, please. So, virtual wards. So this one's quite a new one for us, and it's taken a number of weeks for us really to get our heads around this one, because I think what we would deem as a virtual ward in Dorset differs very much to NHS England's classification of a virtual ward. So for clarity, a virtual ward is being able to provide care for a patient who would ordinarily be in a hospital bed, but provide that in an environment that they would call home. Again, this is partly mission avoidance, but also it could be stepped down, so it's about getting people out of hospital sooner as well. So you'd have this virtual ward that can have an element of a digital response to it, but also have acute level care provided in hospital. And I suppose the best description I can give of that to you would be if you have somebody in hospital having had orthopaedic surgery with a long-standing infection that we'd have on IV antibiotics and could be in hospital for a number of weeks, we could deliver that care actually in their own home in a different way. So that's what a virtual ward is. For us, I think it's really quite important to not just consider the new definition of a virtual ward from NHS England, but actually how we can move patients up and down our whole care pathway from supported self-monitoring through to what we've traditionally called a virtual ward, which may be helping people understand how to manage their long-term conditions, keep them well, be able to escalate if there's a change in their condition or de-escalate. And actually from that aspect also then step them into the virtual ward where it's technically a hospital at home. I'm not making myself very clear, am I? I do apologise. So it's really about preventing admission, being able to try and identify patients who are deteriorating, putting plans in place and care in place in their own home to prevent an admission, but also to support discharge earlier. Next slide, please. This diagram explains the levels of care. So level 1, the preventative care, is the bits that I spoke about earlier, where people are self-managing digitally, and right down to level 4, which is the virtual ward hospital at home model that I just described, and how we would use some of the enablers that we have currently to support that. And one of the other things we're working on at the moment is, next slide please, sorry, is end of life and palliative care in the community. So we've identified that many patients aren't having the best death or the death that they would like. So we are at the moment developing a model of care to support patients in the community a bit more. And that's really looking at what we've already got and approaching it in a very different way. And this is one of the areas where I think actually we could work together as the social services and health to really do something a little bit differently. So for me, this is about really being able to enable people to have a good death, but also take the pressure that the system's currently seeing from end-of-life patients. At the moment, there isn't enough support in the community for patients to be able to die at home. Families are getting into crisis and invariably are calling on emergency services or out of our services to support them in the very last days of life. What we'd like to do in Dorset is develop a model of care that relies on lower level care provision. And that could be having community support workers working alongside health to really encourage people train people and support them to look after people a bit longer than they ordinarily do at the moment at that level. So at the moment, I think we're relying heavily on, let me start again, sorry, backtrack. I'm not doing very well with this bit. Okay, our district nursing teams take on a lot of additional work when they're going in and seeing our end-of-life patients. So they're tending to personal needs a lot more than perhaps we would like them to. And our suggestion would be to introduce some community support workers who would work alongside health that could pick up some of the lower level medical care as well as the personal care. That way freeing up a bit more time for the community matrons to go about and move on to the next patient and see them. We'd look at increasing the level of care that we're currently providing so that those visits could be made 4 times a day instead of 3, and later into the day as well, so that actually there's that end of day between 6 and 10 p.m. visit opportunity that could settle the patient, allow the family some a breather to be reassured, and actually take the pressure off of emergency services. I think we have this to some degree in one area in Dorset, And it has shown that that additional visit and that additional time at the end of the day is supporting families enough for them not to rely on out of hours or emergency services overnight until their next visit comes in the morning. So there's that aspect of it. And then there's also the anticipatory care aspect, where we're actually preparing family and patients for their death. So we did a survey last year to understand from patients and family members how they felt their end-of-life care was going, or from a family member's point of view, what that experience was like. And it was really quite an upsetting read, that they felt completely unprepared. The patients said that they didn't understand what was going to happen to them or what would happen to them after they died. So we're proposing that we introduce an anticipatory care aspect to the model, which would pick patients up a bit sooner in their prognosis, actually spend some time with them to plan their care towards the end of life, prepare them for that, and also provide some weekly check-ins to make sure that actually they're okay. When it comes towards the end of their life, actually, they should be a bit better prepared for it, and their family should. The relationships would be better developed, and their care should actually run a little bit smoothly than it is doing at the moment. That's what we're hoping to test out in Dorset, alongside the Home to Die pathway as well, and that's aiming to get patients out of hospital sooner so that they can die at home. We're hoping the two aspects of that model will join in the middle and provide a better service for our patients at end of life. And any questions?
Is there a second part to the presentation? You weren't? No, that's okay. I was just checking. I was just trying to keep up with where we are. Could I have questions, please, on this?
Thank you, Chairman. I'm not sure whether I missed something here, but I would have found it useful to have that PowerPoint display circulated ahead of the meeting, really, so that we could actually perhaps ask some pertinent questions. Two things which occur to me. I'm not quite certain I understand how the virtual hospital at home works. You mentioned people who'd had some kind of orthopedic surgery and then they were on antibiotics. But I thought you said the hospital at home, or whatever it's now called, was only for 72 hours, which is 3 days. Surely a course of antibiotic treatment would be rather longer than that. And I'm just trying to think how that would work, because 72 hours might work for some types of need, but not others. And I'm also not entirely sure I understand the explanation you've given about end-of-life care and about at what point that kicks in, because in some circumstances it obviously doesn't work in the last 2 or 3 weeks, perhaps, of somebody's life, as I know from experience.
So a moment ago, I explained that NHS England's definition of a virtual ward differed from ours. I think it's probably best to put it into the context of the work that we've been doing historically in Dorset. Probably sits better under virtual care, just to clarify that point. The 72 hours bit, that comes under the urgent community response, and that's for immediate crisis. The virtual wards that's recently come down from NHS England would hold patients predominantly about 2 weeks, but could be up to 6 weeks level of care in that service. Okay. End of life, we would say that somebody could be in their end of life stage for 12 months. We would be looking to put this anticipatory care aspect in about 3 months prior to their death, if that's known. If not, then as soon as possible, and whatever support we need to be putting in place to help them have a good death.
I might just come in here. I think being involved in the palliative care and end of life, everybody has a different understanding of what we mean by those terms. So the work that we're doing is currently we're developing a Dorset-wide strategy for adults and children, but focused on the adults. We've realised that actually there's gaps, as Jenny said, from a community perspective. So even that prognosis, when someone's given the prognosis that they're palliative, what happens? How can we get a better MDT approach to support someone? And then when they deteriorate, what goes in and who? Really getting some clarity about what level of support's required, and then when they become end of life. And what we've found, particularly with the Home First program, when someone's in hospital and they're end of life, wanting to die at home and being able to discharge them, we've had real challenges about that simply because we haven't had the right care necessarily in the community. So we've taken the end of life care element of the Home First program, discharging when someone's in hospital, and created a home to die pathway, which we've just tested actually in the West, and we're working with the East to have something similar. So hopefully if someone wants to die at home, or potentially they might not be able to necessarily die at home, but outside the hospital, and that's why it's so important to work with local authority partners in terms of potentially having some beds that are set aside to support people that are end of life, so that we can get the right support at the right time. So that's what we're trying to do in order to really develop our palliative care strategy.
Thank you. Can I ask a question, please, around your referrals into your Prevent? Because I think you talked about, well, you did talk about 111 being the referral route in. Is that the only referral route, or can GPs refer into this service?
For the UCR, there is no wrong door, so anybody can refer in. So we've had, when we tested this out in the east of the county during the summer last year, we were receiving referrals also from social services where there was a breakdown in care. Patients can refer themselves in 999 111 GP practices and the ED department. The only stipulation is that we wouldn't receive referrals from wards, and that's NHS England's way of preventing that becoming a discharge to assess pathway. But yes, referral sources could come from anywhere.
Okay, so can you just confirm they can come in through social services? Because if DC have got people out there on the ground working with people, they are the ideal people who are watching some of these more frail people.
Yes.
Okay, and just a second question, which you mentioned right back at the beginning about Live Well Dorset. And it's always my concern on these that an awful lot of stuff is actually preventable if you get to people in time. And I've also had anecdotal information about people who are refusing to go into hospital for what would be a routine operation because they're concerned about their care package when they come out again. Are you addressing those sort of issues, particularly around the Live Well Dorset? There are anecdotal stuff about people who really aren't living well, who aren't within the Live Well service, the Live Well Dorset service, and ought to be in there, and how much sort of chasing up, cajoling, encouragement do you do to get people in? There are an awful lot of people there who will just say, oh, I'm all right, and they're really not. They need to be in the service. And that is where a lot of prevention, to me, should be.
I'll probably pass on to Kate about the Live Well bit, but if I could just touch on some of the prevention stuff from an anticipatory care point of view. I think our role there is to actually identify patients, as I mentioned earlier, around risk stratifying our population and understanding cohorts of patients that we could see having a trajectory of decline and stepping in and preventing it at that point there. And for me, that brings in the likes of Live Well Dorset, it could be Active Dorset, and really using those agencies around us to get people to address some of their health needs before they really deteriorate. And I think we've seen quite a deterioration over the pandemic where some of our mild and moderately frail patients haven't been quite so active, and as a result have declined a lot quicker than we would expect them to. So our role is really to identify those patients and approach them rather than from an anticipatory care point of view and service, rather than them waiting for them to come to us. And I'll pass on to Kate about the Live Well Dorset bit.
I think in terms of prevention, this is where we do need to reset. I think with COVID, public health, they haven't been able to sit around the table with us, particularly our primary care networks. So in terms of having that proactive care approach and understanding just where we can make a difference, we've also had conversations recently with local authority colleagues about the telecare. So, you know, there's some exciting things happening, I think, in Dorset Council that would like to integrate into our Ageing Well program so that we can start to get a better sense and actually be able to intervene a lot earlier. And of course, there's primary prevention and secondary prevention. So it's important that we start to have those conversations about how do we have that. It's the health and wellbeing strategy, isn't it, for the system, and what we do upstream. And even for our children and young people, we talk about ageing well. And of course, the focus in Dorset, certainly since I've been here for the last 3 years, has been on our older population, you know, over 65s and those that are frail. And yes, that's an important population, but equally, if we're talking about prevention, we do need to make sure that we don't lose sight of what we do with our children and young people, and that ageing well covers our whole population. So definitely need to reset and strengthen our focus, I think, collectively as a system on prevention.
Could I just ask about mental health? You take into account mental health and refer in as appropriate?
Yes, we do.
Councillor Ireland.
Yeah, it was an excellent presentation, thank you. And most of the questions I've written down then got answered, so it was good. I still can't get my head around the virtual ward. I guess the two questions I have is what does it add to the mix? So in terms of discharge, what does it add that we don't do now? And being a bit more specific, so I mentioned in my declarations my wife works at YDH, and she was on-call manager last Friday, and they had 100 patients fit to discharge and they couldn't get them out. So does the virtual ward that Dorset CCG ICS providing cover patients? Because there's lots of patients in Yeovil who are from Sherborne. A good percentage of the patients in Yeovil are actually inpatients or Dorset residents. So would that service cover that eventuality? And my second question I'll leave to after the answer.
I think in terms of the virtual ward, a virtual ward is no different to a ward in the hospital, except it sits outside that hospital environment. So instead of having a physical ward, you have a virtual ward. So it's the beds in someone's home. You've still got the same level of staffing and resource. So there's a lot of debate and challenge around, is this a less expensive model of care? In actual fact, no, it's just a different way of providing. So you're in a different environment, and it can be technology enabled, or it simply is that care is going into someone's home. So when we talked about the IV antibiotics, we have Dorset County Hospital has a hospital at home service, and that is a virtual ward. So that's the only one we've got in Dorset. So there's a whole team, multidisciplinary team, that actually supports people. So they step down. It's predominantly a step down ward. So people will come out of hospital, they can discharge them earlier. For example, they need IV antibiotics. That can happen at home. So the discharge effectively happens as a step down. So the referral comes from a ward within Dorset County. They refer or talk to their virtual hospital at home ward and their team, and they go in and will provide that care in someone's home. So it's usually sort of up to 2 weeks is the length of time for someone that they might spend in a virtual ward. So it's no different effectively as a ward that you'd normally set up and establish within a hospital. It's just sitting, the beds are in people's homes, but the care is provided by an MDT, multidisciplinary team.
I have a second question. So about the good death, for the want of a better phrase, and timely discharge of people who, ideally to die, pass in their own home or surrounded by family, etc. So one of my daughters is a doctor. She's just finished a rotation in oncology in DCH, so Fortune as well, and places like that. And she was telling me one of the big frustrations she found was that when you get patients appearing who they're not going to die in 12 months, they're going to die a lot more sooner. And there's been an increase, it seems, due to the pandemic. So people haven't been able to get access to GP services, etc. So they're presenting with cancers that are, they're terminal, they're metastasized, or things like pancreatic, which kills very quickly. And her big frustration was that she was to have to tell families that you're going to die your relative is going to die in hospital because you just can't get the care packages and the stuff arranged quickly enough to get you out. And is this going to help? Because I know you mentioned 12 months, and I thought, that's
That's why we're doing the Home to Die pathway in the work, because certainly my involvement in Home First, so I sit on a design and delivery group or part of the process, and I've had a lead role around palliative care and end of life, and it hasn't been good. I think as a system, we could do better, which is why what we've done is focus on, and we've called it Home to Die. So this service or this pathway is about those that actually will die imminently. What we found is that our specialist palliative care teams within the hospital weren't as involved as they used to be prior to COVID and prior to the Home First pathway. So we've brought them back into the model. We've changed the discharge process and the pathways, and we've prioritised this cohort. So the cohort we've got on the pathway are up to 2 weeks, because it is quite difficult to prognosticate, is the word they use, in terms of that, how long will someone live until their death. So we've got our specialist palliative care team involved to help with that on the wards, to actually put someone onto this pathway, hopefully prioritise the care so that we can get care. We've also purchased some additional capacity from Weldmar Hospice to support Murray Curie, so that we can make sure that for those that are on that pathway, we can get the care in place in a timely way. So hopefully they won't die in hospital. Now, we've only just rolled out this pathway since February at Dorset County, but already we've seen a marked improvement. So, certainly the intent is that this will really make a difference, and that we don't get people dying in hospital if that's not their choice.
Sorry, if I can jump in. And the model that I was describing is kind of the other end of the scale, where we're actually trying to prevent an admission and provide a level of care in the community so that patients don't end up in hospital and ultimately dying there.
Councillor Legg.
Thank you. Can I return to those two themes, if I may, again? One in relation to the hospital at home. From what you were saying, there is a resource implication which is just as demanding and just as intensive as there being a hospital bed itself, apart from the fact that the hospital bed is actually parked in somebody's house. And Nick made the comment about Yeovil and about the number of patients in Yeovil who actually have their homes in Dorset. It just struck me when you were talking about the cost of providing this, that actually what you were saying, forgive me for putting words in your mouth, but what you were saying is this is a provision to free up beds in Dorset hospitals, not a provision to free up beds in Somerset hospitals. And secondly, just thinking about the Yetman, and you're talking about the making it possible for people to die at home. The Yetman has got 2 suites, which are end-of-life care suites. I hope that you don't go down a path of saying, well, now we can allow people to die at home, then everybody should die at home. And that the consequence of that is you're going to close down end-of-life suites in the hospitals that we already have.
Just to clarify on the virtual ward point, that service would be for any patient registered with a GP practice in Dorset. So regardless of which hospital they're in, that's that. And I think you asked a question about, so it's not just for workforce, yes, absolutely. Yes, workforce is going to be our biggest challenge, absolutely, with this model. And as I said earlier on, it's not really what Dorset would have deemed as a virtual ward historically. But we're keen to explore other ways of managing patients. So when you're in hospital, you've got 24/7 care, which we can't provide in your own bed at home. So it's about actually looking at the technology that we have around us that can monitor patients when somebody isn't there. And it's almost like, and forgive me for my simplicity, it's almost like having a district nurse that's going around and seeing to patients, but it's provided and under the care of a consultant at a hospital, with the addition of technology to provide additional monitoring and support, is the way that I see that working best in Dorset. And then over to you.
And in terms of palliative care, we've got no intention of closing any of our facilities. In fact, I think, not everybody can die at home. It can be really difficult for families. Which is why, I'm keen to have conversations with local authorities to look at a bedded option as well. So, yes, we're certainly not going to reduce our capacity around end of life.
Right, I think we've just about come to the end of this agenda item. I'm just wondering where we go from here, committee, and just wondering whether we would want an update on some of these things at some time in the future. There's been a lot of discussion about the virtual ward and also the end of life and the changes that are coming in on that. Plus, we've also had an awful lot of information about the pressures that are on the integrated care system through winter and how that's going to pan out into the summer. So am I getting a nod that we would like updates on this at some time as appropriate? Okay, so if I can talk to our guests at some time and just sort out where that would fit into our agenda, that would be absolutely brilliant. The paper does say that it's for noting. I think we've done more than noted it. We've pulled it apart. We've discussed it quite in depth. So, and I hope that you found this really useful. But thank you ever such a lot. And you're free to go now. I don't know, are you staying for the rest of the meeting? Yeah, okay, thank you. If I can move on to the next agenda item now, and if I can welcome Ashley Boreham, who's going to come and talk to us about the update on the treatment centres, and thank you for waiting and being so patient with us. If I can hand over to you now.
Okay, thank you very much. So if we just, you've received already the slide deck for no, I'm just going to go over slides very quickly, no more than about 7 minutes, pull out some permanent points. First of all, I want to thank you for giving the opportunity to engage. This is about really engaging opportunity, but on some of the points that have been said earlier about the ability to influence the way that we force design our healthcare systems in the future. So it's an update on what we've done through the community diagnostic centres and the Dorset Health Village and the direction of travel we want to take. And I've already spoken to the chair and I've looked off the opportunity to, off this meeting, to engage with you and have a discussion as a sidebar to sort of really explore how we can do this together. So, slide please. So the concept of what we were trying to do was deliver high clinical sense facilities in our ability to triage our patients as part of attacking the waiting list that we have in Dorset. So it was a different way of approaching it. And it was going to be using the Community Diagnostics Centre funding in year 1, so doing it rapidly, and using elective care recovery money. Next slide, please. And the intent that I laid out there really was about doing things in a different way, working in the high street, connecting with our communities, changing the hours that we work, and how we engage with our patients. Slide, please. The first site that we went for was centred on the Dolphin Centre on the second floor of Bill's. It's a completely different way of doing stuff, going on the high street, because as was discussed earlier, certain things for our patients don't need to be done in a hospital environment. They can be done outside the hospital environment, and we can build upon that learning. But also it means that we connect with the community in a different way. We breathe life into the high street. And we chose the Bill site based on early engagement about where we could connect to as many people as we possible. And as we know, this is about a first thing. This wasn't about the end state, this is the start point, about how we can create something. And so it was, as I discussed earlier with one of your colleagues, there's not a lot of motorways in Dorset, but they do have some A roads, and there is a railway, and despite the beaching cuttings, we still have an east to west railway line that also comes down south. So and also the buses, really important for people in Dorset. They are the primary moving of people who don't have cars. So getting a good terminus and getting those people connected was really important, and of course the car parking as well. Slide, please. And it started as an idea. It was called Think Big. It was a challenge given to us in March. Slide, please. And the first phase was about scoping. So by March, it was about thinking how we could do this. We then went through drills, options, appraisal, governance. Slide, please. And built into the planning phase where we really built out their work streams, look at the financial model, agreeing the plans, appointing architects and builders and getting moving on. Slide, please. And by then, we moved from summer into October. We began the building in September. We completed the building, the equipment, the installation of the digital systems and connect it to the rest of the hospital systems and our validation checks. And we signed off with CQC at the end of November. Slide, please. And then by 16th of November, we've taken our first patient from an idea in March. Slide. It's really important to understand the modelling. It wasn't just about building a building that's just going to be the same as every building. It was about doing a clinical operating model that focused on the way that our patients are seen, the way that they interact with the consultants, but actually also bringing in the voluntary sector. So you talked about Live Well and Active Dorset. They were part of our partners from the outset to engage with the patients. These are people on the waiting list or people that need to be screened. It's about people that don't know what's going on in their journey. And we know there's 100,000 plus people in Dorset that just didn't know what was going on. That's not acceptable. We had to engage them quickly and early. And we identified a number of key specialities that we wanted to work with us. Breast screening, how could we increase the number of that? How could we put it more into place? Ophthalmology lanes, we looked at musculoskeletal, very good one with Active and Live Well Dorset. And then we created these parties with patients, clinicians, support workers, voluntary sector, all in one place. And we did a rehearsal concept to basically draw the whole plan out on the floor, walk it, introduce people to it, and make it work. Slide, please. And we took these models from this stage into operating models that were engineered process. So in other words, start point from the patient, the engagement of that patient all the way through, and timing those patients all the way through the process. Also the engagement with Active Live Well Dorset, social prescribing, in a space that works for that patient outside the hospital environment. Slide, please. There's another one. This is orthopedics, and this is quite pertinent to Dorset County as well because we're linked on to Southwards House, and the project's going on there as well. Slide, please. And then I shared this as well, this is the design that we came up with, which is all about flows. It's all about flowing patients, engineering, logistics, information, and making sure it works for everybody in a really clever way. So that it's all about reducing the amount of time a patient spends moving between places. And to give you a good example, if you've ever been for ophthalmology and you go to a traditional waiting room, you go to a waiting room, you'll get there an hour early, you'll get pulled into a room, then into a room, you go back to the waiting room. This is actually a pathway where you go from room to room as a patient. You don't go out to there. In fact, there's no waiting room in this facility at all. It's called a gallery because it's also using 2 touch points on an iPad to get you in. It's really about, and the patient navigators, the volunteer groups are vital to make this work as a team. Slide, please. It's got good response. It's the first in the country it's ever been done. National television have engaged with us. The senior leadership, so we've had Amanda Pritchard, Chief Exec, come down to see us. The Secretary of State came and saw us 10 days ago. Because, and other countries, so Scotland have been in touch with us. We're sharing our learning from this. It's a start point. It was a really it was a bold move done, and it was done before we got the money, because we were told to do it in year 1, but with all the things, your money will come later. So Dorset as a system decided to take this as an early thing because we thought it would work. Next slide, please. And then Southwark's House is also being developed. So that's a pop-up clinic. So we basically have taken over and, in effect, leased the ground floor, created pop-ups, engaged again in the same process with a rock drill and with the council and with volunteer groups and the patients, and really asked them what they wanted. And some people said, well, you know, it actually is very good. And some people said, well, it's not permanent. But when we spoke to patients, they said, do you want to wait for 18 months? I want to be seen. Their voice was really powerful why we wanted to do this. But also it's about reducing waiting lists. Some of the waiting lists we've had in Dorset County have gone in literally in months, gone, because they are seeing patients quickly. It's consultants face-to-face. It's a face-to-face with the team. This isn't about seeing patients virtually. It's with the consultant, but it's also with the community physio team. It's also with the Active and Live Well Dorset. So you have one conversation in one place with everybody you need to have a conversation with, including social prescribing. You don't have multiple conversations, you don't have multiple journeys. So it's good for them, and the feedback that we're getting, and we are feeding back from every single patient. The patient navigators are capturing all the way through the ideas on this. Slide, please. And that's just the design, it's just a picture. It was just to illustrate the way the flows work, the way that they've designed. This was co-designed by patients and consultants and the council and Active Dorset to make it work as a flow. So it wasn't about imposing something on people, it was about co-designing, co-producing. Slide, please. And the wider picture. So the wider picture is, slide. Thank you very much. It's the added social value of working with the volunteer sector and working with the Voluntary Alliance, which is now being set up. It's about regeneration of the high street and putting purpose back in the high street by putting the NHS as an anchor institution into that space and increasing footfall and purpose. It's about wellbeing support. It's linked with education, social prescribing. It's working and activating the population in a different way and actually being very visible to that population rather than being hidden. For the right, and for many people, this is about people that are, it's about prevention strategy, upstream engagement, as we discussed earlier. So it links to the health and well-being piece. It's about the whole journey. It's about the environmental focus because we're repurposing buildings that already exist rather than trying to build new ones. So it's very green. And it's a testbed of innovation. So the iPad, you arrive at this thing, navigator, 2 packs an iPad, you go straight to your appointment. You don't wait. If you come early, because you're on the high street, you go and get a coffee, and then you come back. Slide, please. The health village is about, we've created these two things. We need to tackle outpatients, but the engagement strategy now is about how we take this further with the community, with the local councils, with the voluntary sector, and with the patients, most importantly. And how also with commercial and industry and the local enterprise partnerships who also want to invest and make things work better for us, because it's about creating purpose. When using the learnings of the Nightingales and the large vaccination centres, that was about flows and how things flow, and also an opportunity to build on the vision for the integrated care system, the integrated care board, the partnership, the co-producing, co-designing. So, once again, that opportunity to engage is really important for us. Slide, please. It benefits the high street, meets the national policy from other government departments, so you can match fund. You don't have to use NHS money, you can get other money from other areas. Slide, please. It collaborates with the volunteers, which I said, really important. 21 volunteers working bills, 80 volunteers working per day in Southwark's House, building on the work that came out of the vaccination programme about how people want to engage in healthcare. And it's not just having a volunteer, it's training that volunteer, inducting them to work in a different way. Slide, please. They are so important. Navigation, patient flow, check-ins, really, really good way of working with patient navigators. Slide, please. The volunteer sector, this is about bringing youth in, engaging with the youth. So we talked about junior leaders in the NHS, so we talked about workforce. You can't bring junior people to work in the NHS cadets, army cadets, police cadets into hospital because it's a hospital environment, but you can bring them into an outpatient centre on High Street. So we're engaging them. We're not just giving them a certificate, we're actually giving them a formal induction education to healthcare because we want these people to think, I want a career in healthcare. And it's not all about being a doctor, it's about all the other opportunities you can have working in healthcare in the system. And in social care as well. So social care is there as well, because we're reaching out to social care. That's where we need to get these people excited about working in different places. Slide, please. As I said, working with different youth groups in different ways. Slide. Benefits in the community, as I've said already. Slide. Community diagnostics. We use the Community Diagnostics National Programme to help fund this kind of thing. So it's bringing their funding to create health centres We're restricted in the places we go, so we need to work with you thinking about how do we reach out the whole of the community. As a point was brought up earlier, the reality of the situation, where people are accessing. Slide, please. And we learned the key lessons as I described there. That's the lessons we learned, and that's really important. We want to take this forward, but we've got more to learn with you. And the next slide, please. And our biggest challenges with all these things, and they're nothing, things you would not be familiar with, you've seen before, but challenges about how we meet those challenges together and get over them. And I think that's my last one. So thank you very much, and I think I was under 10 minutes. So I can now be ideas for scrutiny now, and to really just press the test and push me as far as you can, and hopefully you'll be kind with me.
Presentation. If I can go over to questions now.
Thank you. These health village centres, are they treatment centres as well as outpatient clinics?
So they can be both. They can be, so we co-design them. In some cases, they will be places where you'll get a walk-in to get a health check. It will be somewhere you may get treatment. It may be somewhere you get screening. And what we've done is we are working really closely with the DICE information system. So we're understanding what the needs of the population are first. So that public health management approach, really understand what the people need. You've got the quantitative bit, because we can do lots of great slide decks with lots of information and data, but it's taking that data to reality of how you can then turn that into engagement with the population. And that's the engagement with the population and with the primary care networks who really, and the GPs, and understanding their role and how they work with us. So we're engaging with Blandford. What does Blandford look like? Does to Sherborne to say, well, how do we deal with the villages? So not every village can have a walk-in health centre, but it's got village halls. So how do we start to work the village hall and that village hall network? But there's no definitive one-stop, this is what it will definitely do. There will be at the highest level, it will have community diagnostics, will deal with MRI and CT, phlebotomy. But as you go down, we start to think about what's happening, say, in Swanage, in terms of what you need there. Now, you're not going to be having MRI or CT there, but it's about, you could be doing DEXA X-ray now. DEXA X-ray is really good for the frailty programme because it's about identifying early onset osteoporosis in women. And therefore, if you can do that early screening, you can then start to doing early treatment understanding. So no one size fits everything. And I think you'd want that approach rather than as being, very saying, this is what will be in there, that and that, and we need to engage.
So does that mean that the picture which we have on one of your slides of the county with various coloured lozenges, saying year 1, year 2, 3, year 3, 4, that more are likely to pop up on there at a later date? The reason I ask is that it said on one of your other slides that the anchor specialities at the beginning were ophthalmology, orthopedics, and dermatology. 3 years ago, my colleagues in Sherborne, the two councillors who represent the town, and I, and Mary, represent the villages around the town, were very exercised about discussions which were going on between Dorset Healthcare and Yeovil for the removal of some of the clinics which were being operated out of the Yemen Hospital, but with consultants from Yeovil. And we felt that decisions were being made without any form of consultation at all. One of the key specialties which we were very keen to retain in the town, in the Yemen Hospital, was ophthalmology. And what worries me a little bit is that by setting up some of these sort of one-stop shops, as it were, the treatment villages or centres that you've proposed, is that everything is being pulled away, and when you look at the map, down to the south, and that what arrangements will be made for cross-border cooperation in the north. Because, there are facilities there at the moment. We're not quite in the Stone Age, and we would like to see them being used properly.
Yep, so absolutely. So a good example about, so community diagnostics is a national programme. There's 162 being built nationally. Kind of a bit of I'll be honest, a kind of an issue, because it's great if you live in Manchester. You can stick one anywhere in Manchester or in London and it'd work, wouldn't it? Because it's just, everybody's near it. it's more difficult when you're challenging the national system and saying what works for us in Dorset, because it's very different models to describe. So what there would be is Yeovil might be, and they may set up a community diagnostic centre. They've got one at Taunton. They might set up one at Yeovil. If they set one at Yeovil, then you start to, what does that relationship between that CDC and the north of the county and Sherborne look like? Because actually you think, well, actually that works really well for me if I can influence what they go in there. So we're already having conversations with the bordering systems and saying, look, if you're going to put something in there and we're going to put something here, let's not put the same thing next to each other, or more importantly, let's not have the thing we need so far away from the population. So we're very early days at the moment. The slide which had the Bills wing thing was about getting early buy-in from clinical teams to deliver effect. So dermatology, we can't, if the consultant says, I'm not playing, I don't want to do this, I don't want to work like this, and sometimes that happens, you need to kind of bring them into the tent. So what you do is you find people that are willing to work with you and actually you think they could work very quickly and get some up running fast and demonstrate success. Dermatology, ophthalmology were really keen to work differently, and so we gave them the opportunity and we co-designed that with them. But actually what's happened is, as we go through, it's a pilot, we think, what else can we do in other parts of the county? What else can we do in a different way? And so we're starting to engage, and it comes back to that point you said right at the beginning when I arrived, about your engagement in co-designing this, not us imposing stuff on you. Even though National is trained to me, you can only have one of them or three of them. Okay, how can I break that out to make it work for us? Because I want to make it work for the patients, and the only way we can do that is engage with you, and that's why I offered up for the sidebars to have a little chat about really engaging with your ideas, because I'm new to the game. I've only been here 14 months, so as they tell me all the time, I've got to learn a bit more Dorset, I've got a London accent, so I've got to drop that somehow as well.
Thank you. Councillor Penfold.
Thank you, Chairman. I have to agree with, with Robin. It's where we both live, obviously we're nearer Somerset than actually Dorset. So in an emergency, if you have to get to hospital, you would choose Yeovil because it's quicker. And that's what this is all about, really.
And absolutely, so that's the point about me engaging with Somerset early, because I think if we can influence them to influence what you need and understand your needs and say, don't just think in Dorset, think about, so it's the same thing as what they put in Salisbury. What's going to the north of the county? Because that works really, because if they're saying we're going to have one diagnostic centre and it's got to serve a larger population, you get drawn to the east, don't you? But then we need to think, well, actually, we're not in isolation. We've got over the border other systems, so let's influence that and make that work for you.
Sorry, yes. Where I live is sort of halfway between, but because it's a straight road, obviously the A37 is direct. So this is why I have to agree with Councillor Legg. Thank you.
And I totally support your point, and I think that's why that's why I want to have that early engagement, so we can talk about where things are going and not dropped in you as another briefing, but actually work towards that. So next meeting's an update, but you're fully engaged with that process. Thank you.
Thank you. Councillor Ireland.
Yeah, thank you. I find it really interesting, the paper, and I'm pleased to see that we're now getting these endorsed. I had a recollections, I just checked it. So one of my other children works for the NHS Confederation. She's a regional director. And she sent me a link back in December 2020 to something that was happening in her patch, which was a trust in Norfolk opening up a Debenhams to do the same thing you're doing in Beals. And there was a HSJ article back in December 2020, which you could look up, which is all about health on the high street. And it works, and I'm glad to see we're doing it. I guess my question was, you mentioned CT scans and things. I don't think you can probably do those in those sort of environments because you need lead-lined rooms, as far as I remember. And the other thing is, obviously, you're now using Southwark's house, of which you're a tenant, and this council owns it. What's your long-term commitment to Southwark's house, or is that confidential? Or, yeah?
The last one is, it's in that stage now of negotiation, so it's probably not here to comment, but I know you will definitely be informed by the right processes. And funny enough, the thing you talk about Norfolk, so we've gone a step ahead. So that was a concept a company called Health Space was doing. We went ahead of the game because we beat them to the thing, and now Dorset's now leading on health on the high street. NHS Confed are now approached us. We're now writing Dorset the national policy for the country on health on the high street because they're seen us as innovators. And so Michael Wood there is now engaged with us, and Michael's now working with my boss, Phil, and we're writing that as a policy. And that's why Secretary of State came down the other day, because he says, okay, you seem to be doing stuff differently here, and we like this. The more important thing is, of course, about match funding. It's about, we're talking about how do we do stuff differently and how do we get money from other places. So if you think about another government department is producing funding through a policy on health and high street and flowing the money into councils, into different areas, you then can co-design stuff and create those things together and use the money better. So it's not just about the principles, it's about the financial bit, which can be quite exciting as well.
Okay, I've got a quick question about, I'm a little bit concerned about your reliance on volunteers. I think everywhere we turn at the moment, we're after volunteers for doing this and for doing that. And I find it interesting that you've targeted young people to volunteer and targeted sort of youth groups, but they're already volunteering if they're part of a youth group. And I just wonder about the longevity of this sort of thing, particularly as kids go off to uni, they leave Dorset.
There's a wider bit. So when we talk about the youth groups, it was about integrating with those youth groups like the Army Cadets that are focused on also about careers. So 4 or 5% of the Army Cadets end up going into the forces. What happens with the other ones? And actually we realise that they are being exposed as part of their responsibility in the cadets to other career opportunities. So it's not, for them, it's not about relying on them as a workforce. It was about engaging the youth to say NHS, social care is a really exciting place to develop a career, and to influence them in that key stage as cadets when they're trying to choose when they're engaging, what do they want to take up as their GCSEs? What are they doing so they can focus on the right area, which is that side of it. On the other side of it, with the patient navigators and volunteers, it's about tapping into, across the county, with the groups that are leading these, about where volunteers want to work and if they want to make a difference. And although it looks like there's a lot, what we do is we found out that when we started at 21 a day at this place, actually we only need 7. And it was also about there are some people that just maybe want to go to a local hospital and help in there and raise money for the charity, but other people want to be, who are in an active retirement, want to do something different and they want to re-engage the community. So this is given another opportunity to work in that voluntary space, but at the same time, it's not relying on them as a workforce, but it's providing that opportunity. So if the volunteers didn't turn up, could we still run the system? Yes, we can, because that would be not sustainable. But what we recognise, though, is to provide the opportunity for them to work with us. So the model has the ability to be agile enough to have both on board. So we don't want to break it when we don't have the volunteers, and we don't want to rely on them completely.
Okay, thank you very much. I don't think there are any more questions. So can I thank you very much for coming today and presenting to us. I think that's been really, really useful. I'm going to ask the committee the same question again, and I know Ashley's been quite clear with me that he would like our involvement in the future, particularly when they're reviewing what's been done and their actions going forward. So once again, I'm going to suggest that I have a conversation with Ashley and we put this back onto the agenda at a time that is appropriate, if that is okay with the committee. Okay, thank you very much. Oh, sorry, Councillor Penfold, just a moment.
For your contact details, because of different things that we could perhaps arrange as councillors and venues and things. So would you be able to email that for us, please? Thank you.
You got my details, or won't share my details. I'm happy to engage with anybody, anywhere, anytime. Yeah.
Can I just thank you again, because I know you've interrupted your holiday to be here, so I very much appreciate it. I would like to say the council will provide it, but I'm sorry, we can't. Thank you. Right, if I can go on to the next agenda item now, which is the Fostering Service Improvement Plan, please. Sorry, who's... sorry, I don't know Gerald Connolly. I'm terribly sorry.
Hello. Very happy to bring a foster carer recruitment update to this committee, and we are looking for your support and noting of our report today. We are joined by Jerry Connell, who I think has not appeared before the Scrutiny Committee to date. Have I got that correct? But he is our service manager in the fostering service. And you will note that obviously normally this would sit with Teresa Levy as the executive director as well. Teresa is on leave, and I'm joined by Sarah Jane Smedmore as the corporate director for care and protection. Happy to take any questions at the end, obviously.
Thank you. If I can pass to you for a brief resume of the paper.
Yes, most certainly. Good morning to everybody. It's a very, very brief update, and hopefully everybody's had an opportunity to read through the paper, and obviously I would welcome any questions at the end of it. It's just to say there's some significant work is being undertaken within the fostering service, and obviously one of the concerns sort of historically has been over the number of foster carers that we've been able to recruit. So in order to be able to address that, as I say, there's some significant work being undertaken. One of those is that we have commissioned a marketing agency. So is what they are currently doing is redesigning our website. So we're going to have a specific microsite. And again, that will bring us up to par with, I would suggest, a number of the independent fostering agencies are out there, because it's obviously really, really important that you're working on the same level. And ultimately, when somebody is considering making an application to foster, they will obviously do a Google search. And again, one of the really important things to do is that you are demonstrating that you have substance, you have coherence, you have knowledge, and ultimately it's that reassurance to foster carers. So as I say, that's a significant piece of work that's been undertaken. The other thing that's been done is obviously sort of realigning how we're sort of working in-house as well. So is what we've now got in place is one inquiries officer. We also have another inquiries officer due to take up that role. We've currently got interviews taking place at the moment. So we're going to have 2 individuals just dealing with that. And is what that means is one of the other sort of key things which, unfortunately, partly to do with COVID, but I think also sort of with some historical issues as well, sort of slightly dropped off the planning, is face-to-face activities. And that's the really, really important thing to do with fostering. And certainly from my previous experience of having worked with a number of IFAs, that is one of the key things, and you need to really supplement the online work that you're doing with that actual direct communication with people. So is what we have is a very sort of clear calendar laid out with the activities that we're undertaking, and that's obviously getting along to events. It's also starting to engage with local businesses, to engage with local sporting groups, so that you start to build up that imprint, that understanding of who Dorset Fostering is. And I think one of the really clear things to do is to ensure that people understand that it's Dorset Council that they're applying to, rather than just to foster within Dorset. Because one of the sad things is that there's a number of foster carers who are sort of spread across Dorset, and they are currently working for independent fostering agencies, which means that, you know, we have this sort of rather sort of challenging situation at times, that we have children, for instance, coming from London, where our previous speaker was from, being placed within Dorset, and yet sometimes we have the challenges of not being able to place within Dorset ourselves. So again, you can understand one of the really important things to do is to try and ensure that we build up that basis of foster carers. And I think, again, one of the sort of the previous directions that have been undertaken, and I'm sort of relatively new into post, one of sort of the previous directions has been just focusing upon new applications to fostering. One of the things for me is also to consider that we have foster carers who are working for other agencies, and it's also really, really important to be able to offer them the opportunity to be able to join us. And I think particularly following on from, our, positive Ofsted report, that, we really have something to be able to offer to people. And again, as you're probably aware, very often foster carers, so if we're looking at sort of Maslow's hierarchy, are the sort of people who are pioneers. They want to make changes, they want to help. And that's something that, we're able to offer them within Dorset. And most importantly, if you're working for a local authority, it means you're not working for an organisation that also has consideration of profit. And obviously, yes, we have consideration around finance, most importantly, and where there can be cost savings, but equally, it's about trying to attract those people. So finally, the other really important thing is that I've been able to build up a really good working relationship with our communications team as well. So again, it's really, really important that we now have communications and we have fostering working together. And one of the things that I do is that we have a weekly meeting with communications, and is what we're able to do is to look at the number of inquiries that we've had online, to consider where those inquiries have come from, to be able to look at the conversion rates, and ultimately to be able to consider if we need to make any significant changes within our recruitment. I hope that's helpful. Thank you.
Thank you. Questions from councillors? Okay. Councillor Legg.
I was looking in Nick's direction because I know he's got some questions and I didn't really want to tread on his territory. So I'm going to defer to him so he can go first if he doesn't mind.
Yeah, I'm happy to go first. So I've been a councillor. I'm a newbie, as opposed to Councillor Parry, who's been a councillor a lot longer than I have, and Councillor Legg, and Councillor Taylor, and many others here. But in the 5 years I have been a councillor, I hear the same things every time. It's about we can't recruit enough people. We need to retain them. I guess it's good that we're going to have a new website, but I'm probably slightly sceptical that, what are we doing differently now that we haven't done in the last 5 years, and how's it going to work? And it's if you look at the paper, there's numbers in there. So it says national churn is about 13%, in terms of foster carers leaving or retiring, but it doesn't actually mention how we benchmark against that. Whether are we higher than 13% or are we less? And the reason that is relevant because it also mentions later in the paper that we recruited 19 in the last calendar year, which is just less than 10% of because we've got 194 foster carers. So is 10% keeping up? Are we treading water? Or are we improving? Because if we're higher than 13%, we're obviously having less foster carers to use. And then another question I've got is, you say you've got 100% utilisation, or you say one-to-one utilisation of the 194 carers. We're using 193 children or something. So is there an implication there that we're splitting families? Because you're essentially saying that each foster carer has one child, or do we have a policy that if you've got a family that requires two to be fostered, do we keep them in the house, or what's our policy on that? Is basically the question. And then my final question was there's a 43.9% that we foster. So of the currently 440 children, which I'm glad to see is less than it has been, we put 43.9% are in foster care. So how does that again benchmark against national figures? Are we higher, lower?
No, hopefully I can remember those. How do we equate nationally? We equate as roughly being the same in terms of our retention of foster carers. I think one of the really important things within that, and perhaps it sort of fits in a little bit with what you were saying as well, it's also about, it's slightly linked with our utilisation rates, because it's also about making sure that when we have our foster carers, that they are able to take the maximum number of children as well. So that's one difficulty at the moment in terms of the number of carers that we have, and a relatively low, I would say, utilisation rate, because ultimately we should be looking at about 1.3 for that. And I think partly that's been related to having a number of foster carers who have just been carrying out respite care. So again, that comes back to having that really, really important recruitment and ensuring that we are getting carers who are coming into place who are able to take on 2, 3, or if need be, if it's siblings, 4 children. And that perhaps again links with the other question that you were sort of asking is, yes, we always try to place family groups together. That is really, really significant. So a very, very good question. It is a challenge. I appreciate that you may have heard some of the similar things, you know, in terms of what we need to do to change. I've come with experience of working in the IFA market. So hopefully I come with some, I wouldn't say, you know, necessarily significant ideas, but sometimes it's about being able to focus that. It's being able to use your resources correctly. And as I say, I'm not being critical of what's been done before, but again, one has to consider that for somebody to be a foster carer, you do not make that decision overnight, you know, and it can take 2, 3, 4, 5 years for someone to decide that. And they may obviously go, well, let's wait until the children are a little bit older. Let's wait until they've been to university. You've got all of these things to consider. So partly one of the issues that we've got is that we are we're almost sort of reaping perhaps some of the poor sowing from the past. So like I say, we've got an awful lot of work to do to try and get up to speed, which is something that we're very, very much doing. Fostering, and I'm still in touch with colleagues within the IFA market. I obviously speak to other local authorities as well. So unfortunately, it is a national challenge for everybody. But I would say that from our perspective within Dorset, we shouldn't fall behind. If anything, we should be pushing ahead. And I think there is a huge opportunity because of the number of foster carers that we know are within Dorset or the surrounding areas. So I would say it's about really having a focus of being very, very active, of really pushing. Obviously, we will do things respectfully and politely, but we really need to push. And I think those are some of the conversations that we need to have, particularly with businesses and with some of the social sort of agencies and so on, because anywhere you should go in Dorset, and it's a wonderful opportunity. And if I sort of think of all the members that there are and the links that you all have with agencies and organisations, we need everybody to be able to really push fostering.
So you've got lots of experience in the private sector, is essentially what you said. Yeah. So my follow-up question, and please only answer what you wish. I don't want you to get into trouble. I used to chair the Shared Lives panel, which is essentially adult foster caring. And one of the things I found frustrating was the amount of time and paperwork it took for when people say, I want to do this, to when it actually ended up in front of the panel. It could be a couple of years. So how do we compare against? So there are competitors, you know, other people out there who are paying foster carers to take, you know, and they're paying them. I know you say it's not a career in the paper, but you know, in the end, you are getting a financial, you know, contribution from either Dorset Council or you know, it's an income for these people. They're not completely altruistic, and I'm sure there's a factor in it. So how are we deficient in terms, or are we deficient? Where do we need to up our game, and how are you going to do that?
I would say there's 2 parts to that. I think the first part is around inquiries. And again, that's really, really important, because if we think that for any of us, if, for instance, you know, you are thinking about getting a builder or a painter or decorator in, there's nothing more frustrating than leaving a message, whether it be online or by phone, and nobody comes back to you. So again, that's really significant. And again, that's where we need to make sure that we're at the top of our game, because you know, many people, when they make that inquiry or they put that application in, for the sort of the quality that we're looking for, these people will have gone to a number of IFAs and then will come to ourselves. And they may go to Somerset as well, and they may go to Devon, and they may go to Bournemouth and Poole, because ultimately they want to see what sort of support they're going to get. So having that immediate response back to them is really significant. So in terms of your question, that's one of the areas where we need to make sure that we are running parallel, if not better, than the independent fostering agencies. The second part is once we've got people on board, and is what I would say is, you know, we've sometimes got to give people that time and space as well. So somebody may make an inquiry and they say, I'm interested, but like I said, we're waiting for the children to go to university, or we're thinking about doing the loft conversion, etc., etc. We've got to be forceful at that stage and say, okay, when you're looking at having this done, tell you what, we'll put a note in the diary, we'll give you a ring on the 8th of June, is that all right? And that way you don't lose it, because ultimately we've got lots of people, for want of a better word, fishing in this tiny little pool, and we've got to be really on top of our game. The second part is, how do we compare with the other fostering agencies and other local authorities with that point of making that application and then going to panel? I would say very, very favourably. So ultimately we are aiming for 18 weeks. And again, I think we have to say 18 weeks as a max. Ultimately, we should be trying to push through for that. And again, that's really important if you're sort of considering if foster carers, you know, want to move from another local authority or want to move from an independent fostering agency over to us. It's really, really important. It's a good question. I hope that answered that, Councillor. Thank you.
Thank you. Sarah James Medmore, I'm Corporate Director for Care and Protection, so work alongside Jerry. One of the other things, and what we know about our foster carers, is actually what support they get from us, as Jerry has said, is crucial. So as a council, we're looking at a Mockingbird model, and what that does is it's a way of supporting our foster carers into constellations. So you asked the question about how do we make ourselves different? What we know from the fostering network and from other local authorities who have brought this model in is actually their recruitment is very good, because foster carers like the model. So what it is it works like a family. This is our fostering family. It works like most of our families would work. If things are tough or you just need a bit of extra support, foster carers work in a group, if you like. They're called constellations, which is lovely because it thinks about stars and how they come together. And you have a hub carer, who's the carer who is the main sort of part of the constellation. And what foster carers can do is they can just contact the people in their constellation at any point to get that support. So it might be that children also get to know those foster carers. That's really crucial, because if you're thinking of family, if it was me, straight away I'd ring my mum and say, please help me, or my sister, and I know that they would step in and do that. And it works in just the same way. So the foster carers know each other, the children all know each other, and then when things are a bit bumpy, or maybe there's just that little bit of space needed, or a bit of extra support, or just somebody to talk to sometimes, the Mockingbird model allows that to happen in a slightly different way to how we can offer that currently. So the council have just agreed to this, this transformation piece. It's really very good. We're working with the fostering network to do that as well. And Jerry will be able to tell you better, but I know already it's created a lot of interest in our own foster carers, which is great. So if we're thinking about retention, that's fantastic. But also, as Jerry said, there are lots of foster carers in Dorset who aren't foster carers for the local authority, and maybe this is a good way to spread the word about some of the great support we're offering. Thank you.
Councillor Legg.
How do these other people who are not currently in our foster care network get to learn about it? Is it just through word of mouth, through other people who... because it seems to me that there are a couple of aspects of this. One is you're saying, well, we're going to change our model and it's going to be a very attractive model to people who want to provide foster care. But if they're actually not part of our network as it is at the moment, how do they get to learn about it? And I thought, Jerry, when you were talking about the consultants that you've engaged, is that just a model of trying to get our, to attract attention to our offer by being at the top of a Google search list? Is that what we're really about? or is it something a bit more sophisticated than that? And just to return to a kind of rather old-fashioned approach and a face-to-face approach. I mean, I noticed that, and I've forgotten whereabouts it is on the list here, there's a table which shows here we are. It's at 11.5, which shows that the predominant age ranges are 35 to 44, which are 32% providing foster care in that age range, and the 45 to 54 age group are at 40.7%. Since people probably would be interested in providing foster care when their own children are starting to get into an older age category, might a good method of approach be to try and engage with schools, and when there are parents' evenings, actually organise a presentation for parents to say, look, you know, if you're thinking about providing foster care, this is what we can offer you as a local authority. Would that be a good approach? I don't know whether you do it already.
Again, very good points that you're making. Sort of very quickly answering about education. Yes, that's already within our planning. We also have to consider such things as doctor surgeries. Again, it's really important as well about how we reach out to the rural community as well. And again, coming back to what you were saying about the idea of, you know, commissioning out and having this piece of work done. One of the difficulties that we've had in the past is that we haven't promoted fostering as we should have done. And if any of you take the time and have a look on some of the independent fostering agency websites, if you have a look on some of the other local authority websites, you will see perhaps some of the differences that we currently have. And it's really, really important that we don't just get level, but we get ahead of the game. And obviously, one of the things that we'll be able to do is to be able to promote, you know, Mockingbird, which is quite superb. I've actually got Fostering Network coming down tomorrow. It's brilliant. They've been able to spend the time. So they are supporting us through this process. And at the moment, there's a number of local authorities within the area are all sort of working on this. So we've got Devon, we've got Somerset as well who are involved within this. But from my perspective, I am not looking at one or two constellations. Is what we want to do is to develop that right out across our foster carers. And there's certainly one local authority in particular which really stands out. We've already had some communication with them. So they are operating on having 10 constellations. So as Sarah Jane was saying, you have hub care in the middle. They don't usually have a placement, and is what they're able to do is to offer that respite, offer that advice to the carers who surround. And surrounding, you can have anywhere between 6 to maybe up towards sort of 10 foster carers. You can see the difference that that would make if we could aim towards getting 10 constellations within, that suddenly that makes a huge, huge difference percentage-wise with our carers. And ultimately, one of the great things with Mockingbird is that, and it started in America, there is loads of evidence to suggest that it reduces placement breakdown. It reduces, therefore, children and young people having to go into residential care, which obviously we always try to avoid. Most importantly, it leads to foster carers being retained. It leads to better outcomes for young people in respect of education, in respect to their health. So being able to promote this, and as I say, as soon as we've got our site up and running, which should be within the next 4 weeks or so, one of the first things that will be doing is, you know, showing that we are piloting, because obviously you have to take a license on from Fostering Network. So that will be showing that we've got those links. That will immediately bring that attention. And how do we get that attention? And I think you're right. And, you know, I always go back to the most important thing is about that direct communication. So again, all the evidence is that most people decide to foster with a particular agency because of word of mouth. So again, it's really important that we have, you know, our own foster carers are looked after, and they do communicate with each other, and they have lots of WhatsApp groups. There's lots of both local and national organisations, so people talk to each other. So it's really important that we start to, as I was saying, get ahead of the game, promote what we're really good at, because I think in the past we have perhaps been really good at some things, but we've just really kept a low profile. And I think now, with the needs that there are throughout the country, we really have to push. I hope that answers your question.
Okay, any more questions? I've got a few. I found this paper really interesting, actually. I found the marketing stuff really refreshing, actually. I think we have got to do something different. I've been around a few years, and at the moment we're not increasing the amount of foster households that we've got, simply because we're losing as many as we're gaining. I find that really concerning. I also find quite concerning that the number of enquiries that we have that go through to fosterers, I think that is just not sustainable. 235 queries in the last year and only 19 going through to fosterers, which I know you're looking at addressing that, but we cannot carry on at those sort of levels, because basically, you know, a bit of extrapolation, you know, we almost need enquiries from 1 in 100 households in Dorset to have enough foster carers, and that isn't going to happen. So I think we really have got to do something different. And we've also got to look at why people are retiring and whether we can just get them shorter term to just carry on for a while. I'd be interested to know why people actually go to agencies. I know you've talked a lot, but have we actually talked to people who are going to agencies and saying, why do you go to agencies? Why do you stay with them? What can we offer you? And what can we put together that would encourage them to come to us and stay with us? Because I'm sure there's migration the opposite direction, where people were foster carers for us, and then they go to be foster carers for agencies. And that is something we've absolutely got to stop. People have got choice. It's up to them. They'll walk with their feet unless we're providing what they want. I've got a question around the foster panel, because this was where this request for a paper came from originally. It was the scrutiny request that we asked to have a look at the foster panel. And I know that's been reformed recently, and I know we've gone through Ofsted and everything, but I would just really value an update as to where we are with that, how that's functioning, how well it's functioning. And I do note, I think you mentioned you were looking at 18 weeks from application. Okay, could you just clarify that? Because in the paper it actually says 26 weeks. So I'd be interested to know which one you're actually aiming at. I think it would be useful, because this came through the performance monitoring, if we could have a good look at the KPIs, whether they're the relevant KPIs that we need, because I think the enquiries to foster carers, that is something we really need to keep an eye on, and we need to know whether we are actually making a difference. And whether it's possible to do that through KPIs, I don't know. And I think just to comment that on our website at the moment, and I appreciate the new website probably isn't up, but there was a comment by some of the children that there was a cost in there, an amount in there that our fosterers would get paid. And there was a comment from the young people that this really isn't on. But apparently it's still on our website. It's still that figure on our website. So if you could look at taking that down. And my only other comment was I get really pedantic. And no, I'm not going to apologise for being pedantic. But we've got in the financial implications, we talk about excess travel, travel for children, travel for social workers, and all that sort of thing. And then we've got in the climate implications, there's no implications. So I'm thinking, well, if people are travelling, you know, if we are serious, this council, about taking our environmental obligations seriously and doing something about it, that to me is actually a bigger winner. If we can say we don't want to travel, we shouldn't be travel this far, we shouldn't be doing this, then we're actually getting somewhere. So they're my comments on this paper. I have to say I was overall, I was hoping we were going to be further forward than we are. But I understand that we are where we are and we can only move forward.
Thank you, Chair, and thank you to the committee for consideration of the report. I was rather reminded when Councillor Ireland made reference to our early days on the county council as was, and I was thinking back to that period of time. And what was quite stark back then was that we were not in a position to tell you the ratios on inquiries to foster carer approval. Our approval times were in excess of 8 or 9 months very often on those that were. And there seemed to be a culture of everything hinged around a fostering fortnight campaign, an annual event once a year. And when we look across the border at those independent agencies, you suddenly become acutely aware that they have an all year round presence on different media platforms, and their comms has been very good. We also were very aware that our offer to the foster carers, and we can't escape the money issues, they do exist, they are a factor in considerations, of course they are. But we were aware at that time that our own offer was somewhat behind the curve of independent agencies, and those were addressed. There's a huge piece of work to do, still to do, in engagement with our foster carers, and I pay tribute to their care and dedication and support throughout the pandemic, which has been beyond anything we could have wished for. They have taken on COVID families at times, and they were shielding themselves, and all sorts of things that we've heard about. But we have had our successes. We recently returned to, during the half term, an event for our foster families, which was held just outside of Dorchester. Highly successful day, bringing together our foster communities and families in those environments. It has been frustrating that a lot of those face-to-face opportunities have not been possible for the last 2 years, and I'm very pleased to see a return to that space, because it is that community of foster carers and how they feel they are being treated and listened to, which really is our biggest sales force out there for finding new foster carers, and we do understand that. I would also say one of the things that I think is important has been the move towards the permanency plans for children coming into our care, and earlier the better, so that we understand if those young people are going to be in a long-term foster care arrangement, whether they will be moving into an adoption situation, or the plan is for them to return to their birth families. Now, we do understand the importance of that, because that will have some impact on where their placements will be. But I have always been consistent in my approach that when it comes to out-of-county placements, I would like to see those to be for very specific reasons, and they are either that it is the right thing for the child to be placed with family members outside of the county of Dorset, or that the level of care they require is so specialist that the best and most appropriate facilities are outside of Dorset. But on the whole, I would, of course, welcome in the first case that our children and young people are placed inside the Dorset Council area, and our preference then is to be with a Dorset foster carer. Thank you, Chair.
Thank you. Could somebody comment on the foster panel, please, and how that's working now? Thank you.
Thank you, Chair. So last time we spoke to you, we were in process really of making some adaptations and changes to our fostering panel. So you'll be aware there is a fostering, and we were at that point going out as well for a new chair. So the chair is in place, very experienced foster panel chair. And also bringing her in has allowed us as well to do some work alongside panel, as panel had been asking us to do around training and development. And I think Jerry will be able to tell you better, but those things have happened, and there is a day with foster care, with the fostering panel coming up, I think within the next couple of weeks. Yeah, he's nodding at me, so that's good. So we're in a conversation with our fostering panel to just make sure that they're feeling that what they had asked for, we are doing, and we're in that constant conversation with them. So we've been able to think about some of the processes as well around the panel, because there was frustration by panel that those processes were too difficult, really, in the way that they were taking place. So we have appointed a coordinator who is a business support person who really just makes sure that those administration processes are as good as they can be. I think with any panel of that size and that importance, there will be bumps along the way, but it's a much improved process to what it was previously. But of course, we keep good quality assurance around that, and we're always striving to make sure it's as good as it can be. There was something else I thought was important to tell you as well. We've also been recruiting panel members. So I think we've had just under 100 applications for people who have a whole variety of skills, really, who are really keen to come along and be part of our fostering panel. So Jerry and his team are just working through those applicants, but safe to say we're going to have a really good selection of existing panel members who have great strengths. And obviously we want to retain them and keep alongside them, but also people who are coming in to join us in that space as well.
Okay, thank you very much for that. Could I just ask about the independence of the panel, though, because there was a few concerns about it being too close to the council at one time.
Thank you, Chair. So panel has to be independent by its processes, really. So the Chair is the keeper of that independence, if you like. So she makes sure that that independence is upheld. She'll report to the Corporate Parenting Board as part of the annual report into fostering. And as part of her role as Chair, she will also be alongside us in recruiting the new members. And she also does the appraisals of the existing members. And if there's any concerns which are raised within those, which haven't been shared with us to this point, I have to say, then we would come up through those processes. So there's good quality assurance processes to make sure that the panel is held in the way that it should be under the guidance.
Thank you. Are there any other questions? Okay, thank you very much. Yes, you can be excused. I feel like the headmaster. But thank you very much for coming, and thank you very much for your input today. And now we're moving on to the Community Safety Annual Scrutiny. And if I can just thank Andy and Councillor Carr-Jones for coming today, and thank you for your patience. Okay, if I can go over to either Andy or to Councillor Carr-Jones to introduce, please.
Get this thing to work without taking my eye out, Chairman. Thank you. And thanks for having us. Obviously, local authorities are legally responsible for helping tackle crime and disorder and creating safe communities. There are numerous legal requirements placed on the council relating to community safety work, covering topics that include domestic abuse, modern slavery, and preventing violent extremism. Some of the duties are specific to the council. Others will involve us working in partnership with local organisations such as the police, the clinical commissioning group, probation, and so on. This committee acts as the council's crime and disorder committee and is legally responsible for scrutinising our community safety work at least once a year. The annual report covers three main areas. That's progress against the Community Safety Plan 2020 to 23, work undertaken to respond to the new legal requirements placed on the Council under the Domestic Abuse Act 2021, and work to prepare for new emerging statutory duties. Examples of our work relating to the delivery of the Community Safety Plan are set out in 11.5 of the report in front of you. These include securing 380,000 from the Home Office to support safer streets and tackle violence against women and girls, and running a high-profile awareness-raising campaign for domestic abuse using our council vehicles. Over the last year, there's been significant focus on tackling domestic abuse, including responding to the Domestic Abuse Act 21, that placed these new legal duties on the Council. These included the requirement for the Council to produce and publish a domestic abuse strategy. The Council received new burdens funding in response to the new Act that is being used to further develop services for victims and their children in safe accommodation. Expectations on the Council relating to community safety have increased over the last few years, and more duties are on the horizon, Chair. These include proposals relating to tackling serious violence set out in the Police and Crime and Sentencing Bill. But, Chairman, I thought it might be useful if I hand to Andy Frost to just explain the way the CSP works for the committee, because I think that it's a complex beast, and it might just be worth him taking a few moments of your time just to show you how the nuts and bolts of the CSP work. Thanks, Chair.
I think that would be really useful. If you could keep it fairly brief, but yes, it would be really useful for the committee, please.
Yes, of course. Thank you, Chair. So the first thing to say, I suppose, is this isn't a new thing. So the requirement for local authorities to work in partnership on community safety came about in 1998. So this is a 24-year period that we've been doing this kind of stuff. Community safety partnerships are the statutory, so legal partnerships that we come together with our partners to work on these issues. And the approach really involves working across those agencies to look at what the needs and issues are in the area through a thorough needs assessment, and then using that to identify priorities and deliver against them. The idea behind all of this is that tackling community safety properly is not within the gift of any one organisation. So if you take subjects like serious sexual offences or domestic abuse, there's no one organisation that's going to solve that issue. So working together is going to have a bigger impact. Recently, our Community Safety Partnership has adopted the functions of the Local Domestic Abuse Partnership Board, which is set out as a requirement in the Domestic Abuse Act 2021. And we have two subgroups of this Community Safety Partnership, one looking at strategic issues, so those kind of issues that require more of a strategic view across the whole council area, so things like modern slavery, domestic abuse, sexual offences, and so on. And a locality-based group which coordinates 6 different groups that are working within individual areas or more neighbourhood issues. And as Councillor Carr-Jones has mentioned, legally, the scrutiny mechanism for that partnership arrangement is through this committee.
Thank you. Have you finished your presentation, Councillor? Okay, fine. What I'd like to do for questions, if we look on section, where are we, 10.4, this paper is in 4 bits. So if we can take the sections one at a time, I think might be quite useful. So if we can look at the progress against progress against the community safety plan, first of all. Do we have any questions on that? I've got several questions. Just talking about our frontline officers on Dorset Council, and when I'm talking about our frontline officers, I'm talking about all of us, because anybody who has anything to do with the public. So, and I'm just looking at training and looking at the training that the police are rolling out at the moment. How well are our officers trained? How much of an understanding of domestic abuse do they actually have? And I'm not talking, I would expect housing and our social workers to have a really good in-depth understanding. So when they go into a house or they have a conversation with one of our residents, they've got that really fixed in their brain and they know what they're looking out for. But I'm just wondering about, say, our highways officers, what they see out there. I'm just wondering about some of our other officers and what sort of training we have and what training is in train at the moment for our staff.
Thank you, Chair. I can pick that up. So we have an extensive training programme around domestic abuse, and it's organised really according to different tiers. So there's a basic level training which is available to all staff, and then the training gets more in depth according to the kind of roles that staff find themselves in, to the point where very frontline practitioners that are working very closely with individuals will receive lots of training opportunities around different aspects of domestic abuse, not just the kind of general theme. So that's available to all staff, and that's a program that we run kind of every year through our training and learning and organisation development. There are other training that we do around different aspects of the council's work. So preventing violent extremism is mandatory training for all staff, and modern slavery training is mandatory for all staff as well. In addition to some of those things, we have learning that comes out of things like domestic homicide reviews, which we take forward, and also we do various types of work around responding to particular issues that we find as we go along. So if for example, we find whole family working. So whole family working is really important in terms of domestic abuse, not just looking at things through the lens of the child or the perpetrator or the victim, but the whole consequence for the family. And once we've learned that kind of stuff, we weave that into our training, and so it's more developed and refined according to need.
Okay, thank you. Are there any other questions on that part? Or can we move on to the next section, which is the Domestic Abuse Act 2021? Questions on that part? Councillor Legg.
Sure, I'm awake here because I'm looking at 11.5, which I think is in the section you've already passed over. £380,000 from the Home Office for the Safer Streets Fund, some of which is to be used to install new CCTV in locations in in Weymouth. Can you just give us a broad idea of how many additional CCTV units would be placed? And is any part of that money being used to enhance the operation of what you might call the control centre, of somebody monitoring the cameras? One of the reasons I ask is we've just had a debate in the Town Council in Sherborne about 6 CCTV cameras, and I think one of the crunch factors which probably has dissuaded us from going down that path is the fact that they wouldn't necessarily be monitored, and all you'd be doing then is reacting after the event. And it just calls to mind a recent item on Spotlight Southwest from on the TV news one evening talking about Exeter, and there was a campaign in Exeter led by the family of a young lady who'd been abducted and murdered. And partway through the presentation of that item on the news, they said that Exeter had 200 cameras already on the streets. And it just struck me listening to that you can have as many cameras as you like, but if people aren't looking at them, if there isn't some effective mechanism of monitoring them, then they're not much use. And I just wonder what is actually happening, how this or some part of this £380,000 is being spent in Weymouth.
That's an interesting question, because I thought the same thing, whether we would have, having seen those CCTV pictures from Exeter, whether we would have picked up on that, because it was slightly odd behaviour. But could I go over to Andy for a response on that?
Yeah, thank you, Chair. This has actually been led by colleagues in the Police Directorate. So we have an equivalent team to mine in the Police Directorate that's dealing with antisocial behaviour, CCTV and so on. But the successful Safer Streets bid has allowed us to have 5 new CCTV cameras at Weymouth Swimming Pool and the Marsh, 5 new fibre optic CCTV cameras at the Rodwell Trail, enhancements of the public space CCTV cameras, and including in the town centre, 2 daytime CCTV monitoring officers, and the control room is being expanded to accommodate the additional cameras. I'm not sure of the details around monitoring, but I'm happy to ask colleagues to get those for you. But part of the whole package was about making sure it all was possible to work effectively with those new cameras.
Is that okay? Or yeah, okay. Any more questions on that part? Councillor Penfold.
Yes, we 12.4 and 12.5, we received an 650,000 on the new burdens funding. Is that sufficient for the additional workload that we have?
Yeah, thank you, Chair. It is, I would say. One of the interesting things that came about with the Domestic Abuse Act 2021 is the new duty around local authorities is to support people who victims and their children in safe accommodation, which is a really important part of our work. It's only one part of our work, but it's a very important one, and that money certainly will help to contribute to those services. And you'll see in the report some of the areas in which we already have provision, but we're certainly with that money able to develop that even further than the current offer.
Thank you. Are there any more questions? I've got a question on the emerging work part. Where does the funding come from for a domestic homicide review? And just looking at the offensive weapon homicide reviews, are they going to be funded by central government, or is this more that is being put onto the local council that we're expected to be doing and we aren't being funded for? Thank you.
So just to start on your point about domestic homicide reviews, which for people who aren't aware is if there are certain circumstances in which a homicide relates to domestic abuse, then the Community Safety Partnership is under a legal obligation to do a review of that situation. There was no funding provided by central government to do those reviews. We don't know at the moment around offensive weapon reviews because that's just a bill in the final stages of Parliament, so that hasn't reached the point of being legislation yet. However, it's encouraging that with the new responsibilities we've had under the Domestic Abuse Act, funding has been applied for that in terms of new burdens funding. So hopefully that's an indication that if there are further responsibilities placed on us, they will come with funding.
I'll keep my fingers crossed, but I won't hold my breath. Are there any more questions on this? Okay. Thank you very much. And thank you for coming today, and it's been really useful, and we'll look out for your next update that I can't quite remember when it's due to come, but I know they're a bit like buses. No, they're not like buses, they're like trains. I don't know. We'll see you again next time anyway. Thank you very much. If we can move on to the committee forward plan and also the cabinet forward plans. I've got an update. Where are we? I've got an update because we had a scrutiny request in about Care South and care sufficiency. So I've had an update from our officers on that because I'm aware there is still an outstanding scrutiny review that is sitting there waiting. Our officers have said that people in health scrutiny have been asked to scrutinise the cost of block care home contract the council has with Care South. A response was provided to full council from Councillor Wharf to a related question in December 2021. The Adult Social Care Commissioning team are currently undertaking 2 cost of care exercises, one for care homes and one for care home and supported living provision. These exercises will enable the council to meet the government requirements as set out in the Market Sustainability and Cost of Care Fund statement published on the 16th of December 21. All councils are required to carry out cost of care exercises and to publish these. Dorset Council has extended the scope to include supported living provision. That will be the Care South in the care homes, won't it? Just so that I'm clear. Oh, sorry.
That's okay. So the care home cost of care exercise will pick up the issue that's been raised.
Thank you. If I can carry on. The exercises are being carried out by independent agencies both of whom are working with the government to develop guidance on what the exercises should include, who will take account of Dorset's rurality, cost of living and workforce pressures, as these are all important factors. These will be important for the committee to be aware of. The exercises will then set out what Dorset Council should expect to pay for care. This in turn will help Dorset Council work with and support the providers to create a sustainability plan. All councils are required to have completed and published their plans by September 2022. Once completed, the council will be able to compare the assessed care of providing care with the prices it is currently paying under the block contracts it has in place. And that, I think, was the important point for the scrutiny and where the gentleman who put the scrutiny request in has been most concerned. It will also take into account, as part of this analysis, any wider benefits of block contracts, as pricing is not the only consideration when assessing the benefit to service users and taxpayers. I'm told that the cost of care exercises will be completed before the end of the financial year. Council officers will then determine the pricing rate and publish this as a key discussion. The information will be shared with providers in advance of that decision being made. The committee are interested in pricing and how this has been arrived at. The outcome of the exercises will be brought to committee in May 2022, which is our next committee meeting. Depending on the findings of the committee, the committee will decide whether further information is needed in relation to the Care South contract. Okay, and thank you very much for Leslie, who's provided me with that statement. And I think several of us have been in contact with the gentleman who is asking for this scrutiny, so we will be looking at it, is my message to him. But it has to be done in a timely manner when we have all the information available from the independent assessment. Thank you. The other statement I've got about our forward plan was that I was contacted on Friday by Grace Evans about our cabinet forward plan, and there is an urgent item going on to cabinet on the 5th of April with regards to the Dorset Centre of Excellence. And I've asked her to give me a brief statement on that, because that hasn't come to us for an option to scrutinise it. I've been consulted and agreed to an urgent item of business being added to the agenda for the meeting of the Cabinet on the 5th of April 2022. The Council has created a company, the Dorset Centre of Excellence. The Council is a shareholder, which is an executive function. The Cabinet will be asked to establish and approve the terms of reference for an executive shareholder committee. Now, it's my understanding that I don't think we've got any of these at the moment, which is why scrutiny will at some time want to have a look. The executive shareholder committee will be governed by the executive procedure rules and the usual council and committee procedure rules: forward plan, publication of reports and decisions, public meetings, and subject to scrutiny. The reason for the urgency is to establish the Executive Shareholder Committee and good governance promptly and in advance of the operation of the company. So this one, there was a slight oversight that this should have been available for us to have a look at on the Cabinet forward plan, but because it wasn't, I have had a discussion with Grace and said, okay, this is okay this time. It's not something I like doing. I've also suggested that she needs to talk to Councillor Bartlett on the corresponding scrutiny committee for his approval as well. So I'm happy to put both of those statements onto our minutes, along with the other stuff from the beginning of the meeting. Now, with regards to our forward plan, I think the only thing that I've got that needs to be added onto the forward plan is that I've asked for some work to be done on dentistry, because I think that's quite an interesting area at the moment, and one that I think we are struggling with a little bit in Dorset. So I've asked for that to be scheduled as and when is appropriate. The other thing are our scrutiny's requests, our scrutiny working groups, that this is a bit like pulling teeth. I am still sitting here trying to get scrutiny requests, the scrutiny working groups off the ground in any meaningful way. And you can interpret that however you want to. I'm getting very frustrated with it, but there doesn't seem to be an awful lot that I can do. And I'll leave it there. So I think, unless anybody has got anything else to comment on either the forward plans, would you please? Yep.
I just had a couple of comments. One, I mentioned to the chairman earlier that we don't seem to have any quality account audits going on that we certainly used to in Dorset County Council days, and we've done a couple at the beginning of Dorset Council, and they used to be a regular item. They would appear. So we would scrutinise the quality account for Dorset Healthcare, for SWAST, but they seem to have disappeared completely off our forward plan. And the other thing is our next meeting on the 19th of May, one of the agenda items is the ICB setup, which is really important because the new Dorset ICS, ICB, whatever you call it, comes into operation, assuming it hasn't slipped in on the 1st of July, I believe. So it would be really helpful if Patricia Miller did turn up in person to give us an update on whether it's going to go ahead and on date and any other use of information which I'm sure she's got to impart.
If I can just update on that, I had a meeting with Patricia Miller last week, and I have impressed on her that this needs to come to us. She has agreed to do an all-councillor briefing, because I think it does need that sort of depth to it. But bear in mind, when we have all-councillor briefings, they're primarily for scrutiny and for overview for us to look at. So I go to an awful lot of the briefings, and I just sit there with my feet up listening. But I think this will be something that we really need to take a look at on scrutiny. I think probably initially it should be overview, but probably in about 6 months' time we would really want to keep an eye on this one. Are there any other comments? Anything else anybody would like to say this morning? Right. Thank you very much. So I've got no urgent business. I've got no exempt business. So I'm going to call the meeting to a halt at whatever the time is, 12:57. And thank you all for attending today.